Good morning, everyone. Thank you for your patience, but I do think our technical issues have now been resolved, and it is time for us to begin this informational session. I'm Andrew Mays. I'm the Insurance Commissioner for the state of Connecticut, and I want to thank you all for joining us at the Connecticut Insurance Department's public informational session regarding the 2026 individual and small group health insurance rate filings for policies offered on and of the Connecticut official health insurance marketplace, Access Health Connecticut. We are joined today, among others, by representatives from Anthem Blue Cross and Blue Shield in Connecticut, United Healthcare, and Connecticut. The department has posted 8 initial proposed health insurance rate filings submitted by 7 health insurers for the individual and small group markets. These filings affect plans that cover approximately 224,000 residents, and that is approximately 158,000 in the individual market and another 66,000 in the small group market. The proposed average individual rate request is a 17.8% increase, which compares to 8.3%, and that was brought to us last year for the plan year 2025. Requested changes range from a decrease of 0.9% to an increase of 28.6%. The proposed small group rate request is a 13.1% average increase compared to 11.9% last year. Requested changes in this market range from 7.0% to 20.4%. The carriers here today have attributed these proposed increases primarily to rising healthcare costs, prescription drug prices, adjustments for deteriorating experience from the prior rating period, year after year increases in utilization of healthcare services, and cost-sharing changes in the individual market related to increases in cost-sharing reductions among Silver Plan members. It is also important to note that these rate requests do not include the impact of the enhanced federal subsidies, which are scheduled to expire at the end of 2025. If these subsidies are not extended, carriers estimate additional premium increases in the individual on-exchange market ranging from 3.5% to 6.8%. As part of our transparent rate review process, the rate filings and supporting documents have been available on the department's website for public review and comment since June the 6th. And a personal note here for those of you who are familiar with insurance proceedings in various states, you do know that what we do here in Connecticut is on the cutting edge in terms of reaching out to the public for information. Most states simply, this doesn't happen. But we want to hear from all stakeholders. Now, you will hear later from our CID actuaries. We're currently reviewing each filing. The CID reviews all rate filings in accordance with the applicable provisions of the Connecticut state law. The only standard under law that we can use to evaluate the rate requests, the only standard are that these requests must not be excessive, inadequate, or unfairly discriminatory. Under the Affordable Care Act, the minimum loss ratio, which is a ratio of benefits to premium for individual and small group coverage, is 80%. Because Connecticut's requirements align with the rate review requirements of the Affordable Care Act, the federal government has designated Connecticut as an effective rate review state. As a result, the federal government relies on the review by the Connecticut Insurance Department of rate filings pertaining to health plans subject to the Affordable Care Act. The CID's review of each filing includes a comprehensive actuarial analysis in accordance with the actuarial standards of practice. Among other items, our department actuaries analyze trend components, including unit cost, utilization, and severity, while also evaluating those trends against historical data from prior rate filings. In early September, I will decide whether to approve, reject, or modify the request. As I mentioned, this session relates to plans that cover 224,000 people, while the total population of Connecticut in 2024 was 3.68 million. So, to be clear, most Connecticut residents are covered by health plans provided by their employers and regulated by the U.S. Department of Labor under ERISA, or provided by Medicare or Medicaid. The Connecticut Insurance Department does not regulate those plans, and these plans are not the subject of today's informational session. With me today are key members of the CID staff, including Wan Chen Chu, Chief Actuary and Assistant Deputy Commissioner, Tricia Dave, Life and Health Actuary Supervisor, Sarah Mu, the Life and Health Actuary. Attending virtually is Deputy Commissioner Jared Koski, and just to my right is Jen Dowdy, Counsel for the Life and Health Division. We will hear a presentation on the changes in federal subsidies and their possible impact from Access Health Connecticut, followed by a presentation on the cost growth benchmark from the Office of Health Strategy. We will introduce the Connecticut Hospital Association and PCMA, the Pharmaceutical Care Management Association, who represent the Pharmacy Benefit Managers, PBMs. We will hear three separate presentations today from Anthem Blue Cross Blue Shield in Connecticut, United Healthcare, and Connecticut on their rate requests, and the department will then ask questions. Following that, the Office of the Attorney General, the Office of Health Strategy, and the Office of the Healthcare Advocate will speak and ask questions of the participants. We will hear from the chairs and ranking members of the Insurance and Real Estate Committee, followed by elected officials and members of the public. Please mute your microphone when you're not speaking and silence your electronic devices for the entirety of this meeting. Again, welcome, and we will begin with a presentation on the federal subsidies from the CEO of Access Health Connecticut, James Michel. James?
Good morning, all, and thank you, Commissioner Mays. I'm James Michel, Chief Executive Officer of Access Health Connecticut. There are many federal changes impacting Connecticut residents, including their health coverage. I'm here today to share the impact of these federal changes on Connecticut residents. Let's begin with an overview of the federal changes. First, do we have any slides, Commissioner? Yes? Okay. Thank you. The second slide would show the three changes that will impact Connecticut residents. So let's begin with an overview of the federal changes. First is the One Big Beautiful Bill Act, signed into law by President Trump on July 4th, 2025. The act includes many provisions that will have significant impact on Affordable Care Act, also known as ACA, customers and marketplaces, as well as the Medicaid program. It is projected to lead to major coverage losses. Another federal change is the final rule on marketplace integrity and affordability, also known as the final rule. This was issued by the United States Department of Health and Human Services on June 25th, 2025. It also includes provisions that will have significant impact on ACA customers now and into the next several years. And lastly, there are enhanced premium tax credits that the Commissioner mentioned that are set to expire on December 31st, 2025. These enhanced premium tax credits were first introduced by the American Rescue Plan Act and extended through the Inflation Reduction Act during COVID. It's possible that the federal government may work to extend them before they expire. However, at this point, there's no indication that they will continue into next year. Can you move to the third slide? Thank you. Now let's discuss the impact of the combined federal changes. We've estimated at Access Health that the total impact of these federal changes can result in 30 to 35% of the current enrolled population in the exchange to be uninsured by 2034. Next slide, please. We have prepared some detailed information to help you understand the impact of specific populations in Connecticut. All data we are sharing in this presentation is calculated using 2025 premiums and eligibility rules. Which means that could get worse if the premiums continue to increase, the impact could be more. For example, And those enhanced premium tax, if those enhanced premium tax credits are not extended, more than 141,000 of our 156,000 customers will receive less financial help. And some will no longer receive any financial help at all. Approximately 28,000 Connecticut residents who have income over 400% of the federal poverty level will lose all their financial help. That's nearly 20% of the population currently receiving financial assistance through Access Health. Let me put that into some context for you. If the enhanced subsidies are not extended past 2025, Connecticut residents receiving financial help could expect to pay more than $3,400 more on average per year for their health insurance on the exchange. And some families earning just over 400% of the federal poverty level would experience significant cost increases. For example, if this is a real family living in Fairfield, currently pays $991 a month for their health insurance. And they receive federal financial assistance of $3,149 a month. If they stay in the same plan next year with no rate increase, they would expect to pay $4,140 a month for their health insurance. That's a 317% increase over the current year. Again, they would not qualify for any subsidy at all if the enhanced subsidies were to expire. We are hopeful that the federal government will act to extend these enhanced subsidies. However, there's no indication at this point that that's in the works. Next slide, please. Now let's discuss the impact to current Access Health customers who are lawfully present but have not yet met the 5-year bar for Medicaid eligibility, which means that they're currently enrolled for health insurance through the exchange with qualifying for subsidized health. If they have income below 100% of the federal poverty level, they will no longer be eligible for financial assistance. We estimate these changes to impact approximately 5,000 current Access Health customers who are enrolled will no longer be eligible for financial assistance. Next slide, please. The final rules, new premium adjustment percentage methodology means the maximum out-of-pocket amount in plans could be higher. Carriers have filed a few non-standard plans using the higher maximum out-of-pocket amounts in anticipation of this new provision. The increased limits represent a 15% increase compared to the plan limits this year. Next slide, please. It's also important to share with you that the One Big Beautiful Bill eliminates the repayment caps for excess advance premium tax credit amounts starting next year. No matter their income, any customer who received excess tax credit amount will be responsible for paying the entire amount of excess premium tax credits to the Internal Revenue Services when filing a return in 2027 for plan year 2026. As you can see, the impact of federal changes on Connecticut residents is extensive and significant. This was a high overview of what's going on at the federal level that will impact Connecticut residents. Commissioner, I'm ready to ask any questions that you or anyone may have.
Thank you, James. I know I don't have any questions for you. I'm just going to look around the room. Does anybody have a quick question for the CEO of Access Health Connecticut? Seeing none, thank you, James. I appreciate the presentation and that information. Next, we are going to look at the cost growth benchmark. As you know, the cost growth benchmark was a measure that was introduced in order to help keep the growth in the cost of healthcare down. The Office of Health Strategy is responsible for that cost growth benchmark. And I will now ask Patty Blodgett, and I'm hoping I got that last name right. Thank you. She's a principal healthcare analyst at the Office of Health Strategy, and she will present to us on the cost growth benchmark. Patty.
Great. Good morning. Thank you, Commissioner Mays, for the opportunity to discuss the Healthcare Benchmark Initiative and share the results from our recent cost growth benchmark report. Also, a special thank you to our elected officials for your participation here today. Next slide. Great. So Governor Lamont signed Executive Order number 5 in January 2020, which was codified in 2022, charging the Office of Health Strategy to set a benchmark for total healthcare expenditures growth, set benchmarks for healthcare quality, and set targets for increased primary care spending as a percentage of total medical spending in the state of Connecticut. I will focus on the cost growth initiative this morning. All right. Here is the logic model for the cost growth program. We have completed the cycle for 3 years now, and we are continuously working to improve the measurement, analysis, and reporting of the data. We also strive to focus on identifying and implementing strategies to slow spending growth. Not only slow, but also rebalance spending away from low-value, avoidable services like unnecessary emergency department visits to preventative and other longer-term healthy initiatives like primary care. And you can, yeah. All right. So in August each year, payers submit aggregate healthcare data to OHS for the benchmark initiative. We then validate and analyze the data, meet with payers and providers during the process, and share initial results with them for review. OHS then reports its findings by the end of the following March and holds an informational public hearing by the end of June. The last step is in October. After consulting with stakeholders, OHS submits a report to the General Assembly, making recommendations, providing policy ideas and avenues for the healthcare system to meet these targets. What are the cost growth benchmarks? It is a goal for how much healthcare spending per person should grow each year. The benchmark values represent a reasonable rate of growth that ensures affordable, accessible healthcare. The current benchmarks were set based on a blend of 80% forecasted growth in median income, which is a measure of what residents of Connecticut can reasonably afford to grow each year, and 20% forecasted per capita potential gross state product, a measure of how the Connecticut economy is doing. The recent report was performance for 2022 to 2023 compared to the 2.9% benchmark growth value. The future 2026 to 2030 benchmark values were recently established at 2.8% each year after receiving guidance from a technical team of local and national experts. The future benchmark value was set based on forecasted median household income and recognizes the high burden of healthcare costs in Connecticut. An additional note is that with the recent passage of Public Act 2594, there is now a provision for some level of accountability to the cost growth benchmark. Effective 1/1/27, if the insurance commissioner determines that a health carrier's average premium rate increase exceeded the healthcare cost growth benchmark for each of the 2 most recent plan years, the commissioner may reduce such carrier's requested rate increase by not more than 2 percentage points in addition to any other rate reduction that were authorized. Okay, so the first thing I want to go over is how is the cost growth measured and reported. There's 2 key measures. I will try to do this relatively quickly. TME, which is total medical expense. This is aggregate data that's provided by insurance carriers to the Office of Health Strategy. The Department of Social Services provides the Medicaid data. The Centers for Medicare and Medicaid Services provides the Medicare fee-for-service data. We also receive data from the Veterans Health Administration and the Department of Correction. All cost growth data is provided net of pharmacy rebates. Total medical expense is how much is spent on each individual in the state, including their own out-of-pocket contributions like copays, deductibles, and coinsurance. Added to TME is the net cost of private health insurance, which is calculated from regulatory reports submitted by insurers or obtained through public sources. NCPHI, or the net cost of private health insurance, is defined as the difference between premiums earned and benefits incurred and includes insurers' operational costs, other administrative costs, net additions or subtractions from reserves, rate credits, dividends, premium taxes, and profits or losses. This brings us to THCE in yellow at the far right, which is the total healthcare expenditures for the state. It's reported only at the state level, where the TME, or total medical expense, is reported at the market, insurer, and advanced network level. An advanced network is a name for a large and organized professional provider group. We do also separately analyze and report all payer claims database data, referred to as the APCD, which provides more granular information about the sources and drivers of spending each year. It does, the APCD, have a different population captured, not the entire self-insured commercial market and not the most recent CMS Medicare fee-for-service data. The APCD, though, allows us to look at payment versus utilization, which both contribute to increases in total spending. All of the data I'm discussing today is cost growth data provided in aggregate by the various sources I mentioned. Okay. So this slide shows the statewide per capita THCE, total healthcare expenditure percentage growth for the last 3 reporting cycles, which is from the beginning of the program. Per person spending growth reached its highest level yet, increasing 7.9% for the state from 2022 to 2023 and exceeded the benchmark for the 3rd consecutive year. So this includes the net cost of private health insurance. This slide shows the total medical expense, or TME, growth at the market level just for the past year. Remember, TME is different from THCE in the prior slide. It does not include the net cost of private health insurance. The state is the gray bar at the left at 8%. Medicare in green had the highest rate of spending growth, and that includes both the commercial Medicare Advantage population and the CMS Medicare fee-for-service population. And the only Medicaid, which is in red, met the benchmark target. The numbers below the bars represent the level of per person per year 2023 spending. The commercial market is in blue at 6.2% growth. It's going pretty fast, sorry, on those slides. All right, all reported insurers for both the commercial and Medicare Advantage markets had spending growth rates exceeding the 2023 benchmark rate of 2.9%. You can see that the growth rates in the Medicare Advantage market are very high. There are a few explanations, but we are continuing to look at this market and are interested to see the future trends in the next reporting cycle. This entire calculation here at the market or at the payer level is the TME, or total medical expense. And just once again, the total medical expense includes individual cost sharing. All right. The next 2 slides provide service category detail for total medical expense at the statewide and then the commercial market. Remember, overall statewide TME growth was 8%. As in years prior, retail pharmacy in the purple, net of rebates, and hospital outpatient spending in red had significant impact. The only service category to decline slightly was long-term care, which is shown in green. And once again, this is the whole state. So long-term care is really attributed to the Medicaid market. Also, non-claim spending had a substantial impact on 2023 statewide spending growth, growing 114%. That's at the top in brown, and that's primarily due to increases within the Medicare Advantage market. The height of the colored bar represents the spending in the category, and you can see the percentage change year to year. So you can see that the red for hospital outpatient is the largest category in terms of the percentage of the total medical expense. And then you can see the growth between them. Now let's look at just the commercial market. Next slide. Yep, great. So quite different in terms of the categories. Remember, for the commercial market, the overall trend from 2022 to 2023 was 6.2%. This is the by service category picture for the commercial market. It had similar growth rates in retail pharmacy at 8.6% and outpatient hospital at 6.9% that we saw in the statewide picture. Notice there's very little to no green bar for long-term care, since that was mainly Medicaid market, and also non-claims in the commercial market is actually negative, and the primary portion of non-claims was in the statewide picture because it's due to the Medicare Advantage market. All right, next slide. Just in conclusion, we now have multiple years of benchmark data and reporting and have a healthcare system that has exceeded the cost growth target every year. This means that the system has not responded to the challenge to slow spending growth to an affordable level that first the governor and then the legislator gave when the benchmark was established. And I have 2 more slides for you. Another benefit of our reporting is the ability to compare Connecticut spending on a consistent basis with other cost growth benchmark states. There are 8 states with benchmarking programs. This slide and the next provides a comparison over 5 years to other states. This slide shows the overall reported statewide cost growth percentages, and this is the THCE, or total healthcare expenditures trend, that includes the net cost of private health insurance. We left off Washington, California, and New Jersey, which are all relatively newer benchmarking states because they did not have the same amount of historical data. And you can see where Connecticut falls. And similar trends year over year between the states. Each state has different contributions in terms of Medicaid, Medicare, and commercial. And oh, good. So this slide is the comparison in just the commercial market. And you can see where Connecticut stacks up there. This slide, as opposed to the last one, is the total medical expense. So not, at the market level, we only report the total medical expense, not the THC or total healthcare expenditures. Thank you very much. You can contact us at the Office of Health Strategy. Please read the 2025 Cost Growth Benchmark Report available on our website, and keep an eye out for the Office of Health Strategy Benchmark Recommendations Report due in mid-October. And it was a pleasure to be here today. Thank you.
Thank you, Patty, and thank you to OHS. As mentioned, the Cost Growth Benchmark Report is available on the OHS website, and there will be an upcoming report in October. Now, I would like, we've heard a lot about cost drivers, and we've seen the numbers. I would like to welcome 2 groups that are a part of, they're stakeholders in this, and I want to hear from them. First, I'm going to ask the Connecticut Hospital Association to introduce themselves, and then the PCMA. So let me begin with Mark from the Connecticut Hospital Association. Mark.
Thank you, Commissioner Mays. Connecticut, it's notable that Connecticut leads the nation in delivering high-quality, innovative care. Connecticut hospitals form the backbone of a healthcare delivery system that has achieved so much, yet faces persistent and emerging challenges to sustainability, affordability, and access. As we focus today on insurance rates, it's vital for all stakeholders here today, from insurers to providers to regulators to lawmakers, to work together to understand and address the issues that make it hard to advance exceptional care and remove barriers for patients. I'm grateful for the opportunity to provide insight on these challenges from the perspective of hospitals to further the dialogue around how we can best protect care and access for all. Connecticut hospitals and health systems continue to face extraordinary financial pressures. Expenses are persistently high, hospital revenues are lagging national levels, and government payer underpayment in particular creates an enormous strain on hospitals and their patients, and indirectly employers and the insured. Though hospitals rely on multiple streams of revenue to sustain their operations, to cover their operating expenses, long-standing underinvestment in Medicare and Medicaid continued to erode the financial stability of hospitals, and it's a major driver of the mounting pressures that hospitals continue to face. Like any other industry, hospitals face broad economic pressures such as inflation, the rising cost of energy, ongoing supply chain issues, workforce shortages, and rising operational expenses, including, for example, the cost of prescription drugs, and also salaries as a result of the workforce shortages, especially for nurses and non-clinical, non-executive personnel. Unlike many other industries, hospitals cannot absorb these losses or make cuts without directly or indirectly impacting patient care. As hospitals seek the revenue necessary to sustain operations, the depth of the government payer underpayment and the inability to negotiate with government payers for payments that cover the cost of care leads hospitals to seek to make up that underpayment from commercial payers. If you have a gap in revenue for expenses that are associated with governmental payers, Medicare and Medicaid, there is no other way to balance your books but to go to the commercial sector. So in short, if we want to address commercial affordability, governmental payers must pay their fair share, and they are not doing so today. Looking ahead, these cost pressures will only mount with the recent passage of the One Big Beautiful Bill Act, as it creates immediate concern for coverage losses of the sort that James Michel just outlined with respect to Access Health Connecticut, but also losses due to changes in Medicaid eligibility, a number of different changes that will unfold over time that could reduce the Medicaid coverage by 100 to 200,000 lives, according to the latest estimates of Medicaid and the Office of the Comptroller. These patients will still need care, and hospitals will, of course, provide that care. They may provide it later because people are getting services only when their needs are so great that they present to the emergency department or are admitted to inpatient settings. In addition to this immediate, as a result, hospitals are expected to experience a significant increase in their uncompensated care or unreimbursed care. And again, charity care, discounted care, unreimbursed care ultimately falls to the commercial payers to make up that gap. In addition to the immediate threat of coverage loss and increased patient volume, the cuts to Medicaid payments or potential cuts to Medicaid payments, hospital tax increases, and related restrictions, both federally and through the most recently passed state legislation, create even more pressure and uncertainties that will only further increase the costs faced by hospitals and their patients. I'm happy to speak in detail on any of the issues that I mentioned, and at that point, we'll sort of cede for questions.
Thank you, Mark. I'm going to have some more questions for you. We're going to hear from Sam first, but I do have one question I would like an answer to, because I want to make sure I heard this right. We've heard in these hearings that there is no cross-subsidization, that commercial payers, the people who are paying their premiums here, are not subsidizing the people that are in government-run programs. You seem to be telling me something different. Is that accurate?
That's right.
Thank you. Just want to make sure I got that right. Sam, can you tell us a little bit about yourself and the role of PCMA?
Sure. Thank you, Commissioner. So hello, everyone. My name is Sam Hollemeyer with the Pharmaceutical Care Management Association, otherwise known as the acronym PCMA, and I'm Senior Director of State Affairs. And I'm here on behalf of PCMA and its members to discuss the role that the PBMs play in the prescription drug market. So PCMA is the National Trade Association representing those PBMs, and PBMs administer prescription drug benefit plans for over 275 million Americans. I want to thank the Commissioner and the department for the invite today to participate in my first rate filing hearing. And I appreciate the department for working with PCMA and its members on delivering prescription drugs to patients in Connecticut. So I start off with this point on almost every hearing that I participate in Connecticut, is that no one is required to use a PBM. There is no state or federal law that states that a plan, such as the State Employee Plan of Connecticut, has to contract with a PBM. But due to the purchasing power of PBMs and their patients, they can negotiate directly with drug manufacturers to get discounts, and they can also work with pharmacies to create networks for patients to be able to visit to get their drugs. So PBMs do offer a whole host of other services, such as claims processing, looking at drug-to-drug interactions, pharmacy networks, et cetera. But since we're here today to discuss the rate filings and drug costs, I'm going to focus my comments mostly on that. So PBMs exist to drive down the cost of prescription drugs. Additionally, PBMs have no say in the price of a drug that drug manufacturers set. That alone is done by drug manufacturers. So the Office of Health Strategy held a public hearing just after the legislative session, where they invited two panelists to present at this meeting. One of them was from a health public policy space, and the other person was from a pharmacist within the supply chain. And the question that was asked is like, what is the reason for high costs? And both answered bluntly with the prices the drug manufacturers set. Those drug manufacturers were also invited to participate in the OHS meeting, and they declined to participate. So to combat this, PCMA and its members encourage state and federal lawmakers to encourage more competition in the market. The more competition that there is, the lower prices that there will be. Additionally, we suggest that lawmakers take a look at the patent thickets that drug manufacturers use to keep competition that I just mentioned away. PBMs also negotiate discounts, otherwise known as drug rebates. And based off the Connecticut Insurance Department rebate report of 2025, PBMs pass back 98.9% of those rebates back to plans. So there's just some high-level comments and a brief overview of what PBMs do within the market. I'm happy to be here today, and I'm also happy to answer any questions.
Thank you, Sam. Thank you, Mark, for being here. Let me start off with a question for Sam that refers to what basically I think I heard you say. The problem with drug prices is that people making the drugs. Now, we know that pharmacy trends continue to be the biggest factor in driving increased medical costs, ranges from 10 to 17%, depending on where you are. We rely on, and by we, I'm saying most insurance companies have PBMs, and frankly, most consumers do not necessarily have a choice as to whether or not they can use PBMs. It's what your plan does, and you go along with it. So you're in many ways standing in lieu of the consumer. Part of that, as you mentioned, is because of the market power that you bring. Clearly, we still have issues. We have seen the administration and the federal administration move to essentially price controls. Would you support the state moving to price controls on some drugs? And if not, or even if you do, what other measures can we as regulators, legislators, members of the state government take to protect consumers?
Sure. Thank you for the question, Commissioner. So one of the concerns I have with the state setting prices is I just don't know if that's going to be legal in the end. And I know that drug manufacturers have filed lawsuits with the Inflation Reduction Act and other pieces of legislation. And most recently, the administration outlined the most favored nation policy as well. And I know they're reviewing that and taking a look at if that's legal or not. So to answer your question, I just don't know if even if the state did pass laws to regulate drug prices, how drug manufacturers would react as far as lawsuits. So PCMA doesn't take a position on setting prices.
So let me ask you, because there are two types of drugs that I see driving up the cost. One is the new, essentially individualized drugs, which can be very expensive, but are also in many cases life-saving. And then there are your basic generic drugs, your insulin, your diabetes, other diabetes drugs. These are drugs that are generics that, the research went into them a long time ago, yet we still see costs being driven up. What would you propose that we do in order to reduce the cost of those drugs, whether they're generics or, increased competition? How do we increase competition? How do we get biosimilars in use? What can we do as government? How can we help people?
Sure. Happy to answer that question. So increasing competition is the simplest answer that I can give you. You just mentioned biosimilars, creating a pathway for biosimilars to be allowed within state formularies and plans. I think that is an important step. I don't know if the state can do this, but the patent thickets that drug manufacturers deploy is also an issue that blocks competition and other drugs from entering the market. Just anything we can do to increase the amount of drugs in any sort of space for them to compete against each other, which we think would result in lower costs.
Thank you. And I'm hearing that the microphone is not picking me up correctly. Is this good? I'm leaning as close to it as I can. But I know the AG's office is here, and they will speak. They will have questions later. But I do want to reference Attorney General Tong's statement. And this was concerns about the growing costs that are associated with hospital-based services, prescription drugs, and whether the filings reflect double counting. The AG has made repeated requests for managed care companies to protect their members and Connecticut consumers by negotiating lower allowed fees based on the actual cost of services and the benchmark. And he went on to say, quote, "It is abundantly clear that insurers are perversely disincentivized from driving down unit costs through negotiation of lower fees, and they're likewise strongly disincentivized from applying close scrutiny to the codes used in provider claims." Now, I'm going to ask you compound question here. One is, do you believe this is accurate in a system in which you essentially get paid a percentage of the incoming revenue? Is this accurate? And would you agree with it? How can we address it? And one thought, that's one thing that's done in a number of states, is to give the AG's office the authority to review individual contracts. Do you think that would help in Connecticut? And I'm going to start with Sam, but Mark, you got the same question coming to you.
So the first question, just to repeat it back, is, how do PBMs get compensated on their services? That can depend on the contract and the plan sponsor. So I'll just keep using the state employee plan of Connecticut as an example. They will contract with the PBM and they decide things from copays to formularies to to the pharmacy networks, things such as that. But it also includes how a PBM is compensated for those services. It can be a flat fee. It can be based off how much money the PBMs are able to save or negotiate on behalf of those plans. So to answer your question, I don't think there's just one way for a PBM to be compensated. It can all depend on what the plan sponsor wants to do with their PBM.
And Sam, let me ask you this. You mentioned there are a number of ways that PBMs are compensated. Is there one, or are there a couple ways that are used by more of your clients?
There's a couple ways. I mean, it can be based off just a flat transaction fee. That's certainly one way that a plan can do it, or it can be based off a couple of other factors, such as performance guarantees that a plan or PBM might meet. That can just be one component, and I can follow up with all the different types of contract options there are.
Thanks, Sam. Let me turn it over to Mark now. The idea of the rising hospital costs, the lack of review of the contracts with the hospitals, what else can we do? How can we help keep costs down?
Can you, Commissioner, can you help me a bit with the analog to PBMs in terms of why you think market principles don't apply?
Thinking market principles don't necessarily apply to healthcare is probably not, it's probably widely agreed to, frankly, given that this is an imperfect market where information on one side is much greater than information on the other. And conversely, the need on one side is usually more acute than it is on the other. What the AG has said is that while insurers are disincentivized from driving down fees, from driving down costs, essentially because they are making a percentage, and I'm oversimplifying it here. Percentage of the premium goes back, so the higher the premium, the more money they make. But that also means in many ways that hospitals are not necessarily driven to lower costs, because if you can get what you're asking for, why would you lower your cost? And that's what I'm trying to figure out here. How do we change the system so it's properly aligned while maintaining the quality of our system to reducing the cost to make insurance and healthcare affordable for everyone?
So, Commissioner, I'm not sure we're all in agreement. So I would certainly see that healthcare is an imperfect market, but I do believe that market principles do apply in terms of hospitals competing to negotiate prices that are sufficient to sustain their operations, which is exceedingly difficult for the reasons that I stated, but that also are competitive with other hospitals that offer similar services. You'd only have to drive 30 minutes to get from hospital A to hospital B that may be owned by a different system. There are many different market areas where there are three or so market competitors, and that serves effectively to keep prices down. So I'm not sure that there's not consideration for the choices that that payers have and that the insured have in terms of where to go for care. And increasingly, there's more transparency on price, and in addition, there are requirements, not only ways for patients to understand what the costs are, but the rates are being published under the federal rules that were enacted over the past several years. Hospitals, that said, hospitals are committed to driving as best they can affordability, because the viability and sustainability of our healthcare delivery system and the level of access and quality that we provide to patients today in Connecticut. In order to protect that, access includes being able to obtain affordable insurance. It is, I think hospitals recognize it's in their best interest to manage as best they can the cost of care. And that is one of the things that all of the hospitals are committed to, is optimizing clinical efficiencies and the effectiveness of the services they provide to ensure that they're as low as possible. In addition, hospitals have committed to the cost growth benchmark, which was discussed previously in the OHS presentation. There's a strong commitment to the principle of achieving cost growth benchmarks, although we have significant issues with the way the cost growth benchmark is administered, and especially that it completely disregards the fact that Medicare and Medicaid payment is insufficient. So when, Commissioner, you maybe attest that, well, we're not seeing evidence that hospitals are trying to control their costs. There's no evidence that the market is working. We haven't yet addressed in this state the most significant factor that drives hospitals' inability to provide to do their part for affordability, and that is Medicaid underpayment on the order of $1.4 billion in fiscal year 2023 and $1.38 billion for Medicare in that same year. You questioned you opened your remarks with, this, so you, Connecticut Hospitalization, Mark Schaefer, are saying that there's a cross subsidy at work. And that idea as to whether you believe in the cross subsidy is critically important because it has implications for whether you think that the hospital's negotiations are gratuitous in terms of what they're looking for, or simply what it takes to make ends meet. With profits that have been razor thin or negative in 2023, 2022, operating margins were negative both years for the industry in aggregate. And a big part of that is the Medicaid shortfall. If you consider a four-member family, you've got a couple, you've got two kids, the household has expenses of $75,000. The husband makes $50,000 a year. How much does ask yourselves, how much does the wife have to make in order for the household to meet its expenses? If the husband's salary over years doesn't keep pace, let's say he gets no rate increases for 3 or 4 years, and the expenses continue to go up by 3% a year for the household, where does the household go to get the difference made up? It's ultimately the other breadwinner in the family has to make up the difference. So the fact is, just like in this family where the cost of supporting the household costs for having a husband, wife, and 2 kids is really a collective cost, it's exactly the same with hospitals. Hospitals have operating costs that serve everybody. People for whom they provide free care, people for whom they provide Medicare coverage, people for whom they provide Medicaid coverage, and people on the commercial insurance market. And together, the revenue that is generated by each of the payers together has to be sufficient to cover the substantial costs of the operating expenses, especially including in the face of years of historic inflation. Medicaid's increases during the period of the settlement have been around 1.5% to 1.75%. And I think and everybody around this table knows that inflation has far exceeded that over the last 5 years. And so there's a perfect example where Medicaid simply isn't keeping pace and there's nowhere for hospitals to go. And consequently, what we see in terms of hospitals needing to negotiate rates sufficient to cover their costs is not necessarily a failure of competition or market principles. It's a function of how we're not considering all of the payers in their entirety. And it's an issue in the administration of the cost growth benchmark to turn blinders on the Medicare and Medicaid shortfall and to assess commercial cost growth at 2.9% as though that underpayment and diminishing shouldering of expenses has no effect on the commercial cost growth. Thank you.
Thank you, Mark. I've got one last question for you. As we look at the cost structure, however inefficient, however it may be, however inequitable it may be, the overall cost seems to be growing. What cost containment measures are your hospitals taking in order to try to reduce that overall cost?
So like most businesses, the hospitals are do their best to negotiate the most favorable supply chain costs they can, even where they may have very little leverage. So whether it's prescription drugs, whether it's other medical equipment and supplies, they work on preventive care and clinical innovations that can make care less costly to get the same outcomes. Those are the clinical efficiencies that we're talking about. So they are focused on having better outcomes at lower cost and developing using the latest technologies to create more clinically efficient workflows. So they're looking at any of the waste within their operations that might have been there last year and how in future years they can continually modify or innovate in the area of clinical services and operations in order to keep those costs to a minimum. But at the end of the day, the inputs are what the inputs are. If you have tariffs, as we've seen over this past year, there's not a whole lot you can do about that except figure out sort of to whom those costs are going to be passed on if you're going to continue to protect access to those who are most vulnerable. Because again, hospitals uniquely have to serve everybody who comes through their doors, and they maintain many service lines that they're operating at a loss. They're providing free care and they're providing care that simply doesn't meet expenses, but they're doing that because the community relies on their commitment to providing essential services.
Thank you, Mark. And yes, we'll do one quick question.
Thank you very much. Mr. Schaefer, when you negotiate with health insurers.
Could you please identify yourself?
Oh, I'm Tom Ryan from the Attorney General's office. When you negotiate with health insurers, and you ask for an increase, do you open your books to them and show them exactly what the cost is of a good or a service? I mean, typically in other areas of the law, like for example, labor law, if an employer, they call it pleading poverty, says I can't afford something, they are required to open their books so that actually the other side can see their cost and understand whether, how to negotiate off of that. We've put pressure on insurers to look at the actual unit cost, to negotiate based on cost plus a reasonable profit margin. They can't do that if nobody can see those costs. Do you open your books when you ask for increases?
Mr. Ryan, as I'm with the trade association and not with the hospital, I'm not really privy to what happens in the negotiating room. I think it's a reasonable question, but I can't really speculate as to how much. I believe from my colleagues at hospitals do provide evidence of the costs that they're subject to that need to be met in order to, again, sustain operations in the way that I described, but I can't provide you with any more detail than that.
Is that something you could share with the commissioner at a later date?
Yeah, yes, I can. We can circle back with our members and provide you with some information.
Thank you.
Thank you, Mark and Sam. I think it was important for us to understand the market. because we cannot understand what's going on in the health insurance market unless we understand what's going on in the healthcare market. We need to understand the drivers of the cost growth that we are all here to address in order to keep health insurance and, again, healthcare affordable to people in Connecticut. So I want to thank you for being here. I appreciate your presence. I appreciate your sharing information with us, and please follow up with any information you think that we should know as we move forward. Thank you. Now we will transition to the carrier presentations, and we're going to start with Anthem, and next will be Connecticut, and then we will end with United Healthcare. We're going to begin with Anthem, and I will ask each group to introduce themselves as they start. And Anthem, all yours.
Thanks, Commissioner. Good morning, Commissioner Mays, members of the Department of Insurance, members of the Connecticut State Legislature and Connecticut officials, and members of the public. Thank you for the opportunity to be here today. My name is Brandon Rousseau, and I am here on behalf of Anthem Blue Cross and Blue Shield in Connecticut. I serve as Anthem Sales Director for the individual, small group, and large group commercial segments. Joining me is Tu Nguyen, Anthem's lead in actuarial strategic planning. We are here today representing Anthem to discuss and present our proposed rate adjustments. Our proposed rate changes are essential to ensuring the long-term sustainability of the markets we serve, allowing us to continue delivering affordable, accessible, and high-quality healthcare services to all of our individual and small group policyholders here in Connecticut. At the outset, I would like to say we understand and appreciate that the Insurance Department's charge of reviewing individual and small group rate applications is always complex. In this uncertain environment, the department must ensure that the requested rates meet the statutory criteria, requiring rates that are adequate and not excessive or unfairly discriminatory. The foundation of a stable insurance market lies in products that provide value to consumers through premium rates built upon a known set of conditions, allowing for the broad and equitable spreading of risk. Anthem is here today to present our 2026 individual and small group rates. Anthem is seeking a 14.2% average rate increase for our individual plans, which insure approximately 84,000 members, and a 13.2% average rate increase for our small group plans, which insure approximately 49,000 members. We emphasize that we are the only carrier that continues to serve all segments of the health insurance market, and our 2026 rates for the individual and small group markets are among the lowest available. What distinguishes Anthem from other carriers is the balance we strike between national scale and local presence. This balance allows us to deliver industry-leading innovative products, distinctive service, simplified transactions, and world-class technology with the benefit of local expertise and experience from our 1,400 associates who live and work here in Connecticut. We serve over 109 million consumers nationwide with more than 1.2 million members here in Connecticut alone. Anthem is proud to have been a part of the Connecticut healthcare community for 89 years. Last year, we contributed more than $1.25 million to our Connecticut communities, including support for organizations like the Governor's Prevention Partnership, Wholesome Wave, Count the Kicks, the American Heart Association, Special Olympics, the Connecticut Children's Foundation, the American Cancer Society, and the Boys and Girls Clubs of Greater New Haven. Our unique business model allows us to maintain a strong local presence, including a fully dedicated Connecticut leadership team. Our local team understands and meets customer needs and builds positive long-term relationships with our care providers and our communities. Our provider network includes all of the state's general hospitals and over 30,000 providers that include PCPs, specialists, APRNs, and more. Now, turning to our specific rate applications. They reflect what we consider to be the most significant challenge facing the marketplace today, the increasing cost of healthcare. There are many factors that drive our premium request. Year to date, both medical and pharmacy costs are trending up as compared to the prior year. Behavioral health utilization continues to run high across all service categories, including inpatient substance abuse disorder treatments and outpatient and office-based therapy programs. We are expecting elevated medical costs in the ACA exchange plans, and we are seeing unprecedented cost trends. We are continuing to monitor these trends and their premium impact very closely, but we want to highlight the alarming challenges that health insurance carriers are experiencing. In addition, the uncertainty around the extension of the enhanced premium tax credits, which are due to expire on December 31st, adds to the volatility in the marketplace. We must underscore that the volatility in the marketplace impacts the whole healthcare delivery system. That includes our brokers, insurers, providers, and purchasers of healthcare. Amid these challenges, our role as a healthcare leader becomes even more critical, reinforcing the importance of our continued efforts to drive meaningful change in the system. At Anthem, we remain steadfast in our mission to expand access to high-quality, affordable healthcare. Rooted in Anthem's longstanding presence in the Connecticut health insurance market, our commitment to transforming the healthcare system is driven by innovation, with the goal of delivering greater value to our members and provider partners while enhancing long-term sustainability. We recognize that care providers' dedication to their patients is the cornerstone of our healthcare system. That same passion fuels our work every day as we collaborate to deliver better outcomes. Together, we are making meaningful strides by providing individuals with access to personalized, integrated care, empowering providers through innovative payment models, clinical collaboration, and reduced administrative burden, and simplifying the healthcare experience to make it more affordable and effective for all. Advancing health together reflects the meaningful progress we achieved in collaboration with our care provider partners. By going beyond contracts and building genuine partnerships, we are driving whole health improvements, one person at a time. This is how partnership leads to progress. Active partners go beyond the contract to make a real impact on health together. We support care providers nationwide by contracting for outcomes, using payment models that support patient safety, drive affordability, and enhance the consumer experience, collaborating for success with tools and resources that make it easier to access data that support the right care decisions at the right time, and connecting for health through linked services for complex care management, pharmacy, behavioral health, social needs, and home-based care. Value-based care payment arrangements, primarily those involving shared risk, mean that both care providers and payers share financial responsibility for the cost and quality of healthcare. These agreements can help fund care providers' work to enhance patient outcomes, safety, and experience. Data around value-based care shows it leads to improved quality, heightened patient and care provider satisfaction, and better access to more affordable healthcare. To help drive these outcomes, we've invested in value-based contracts for more than a decade. By equipping care providers with well-designed economic incentives, actionable data insights, and expert consultation, we help them improve their patients' whole health while meeting agreed-upon performance standards under shared risk arrangements. In these arrangements, both providers and payers assume responsibility for the cost and quality of care, aligning incentives to deliver better outcomes at sustainable costs. We have made significant progress in advancing value-based care across our Connecticut markets. Today, 65% of our total medical spend in commercial and Medicare Advantage health plans is tied to value-based care arrangements, with 57% of that spend in shared risk contracts. By recognizing high-quality, efficient care through appropriate value-based arrangements, we've seen positive health outcomes across all populations and lines of business. Additionally, value-based arrangements create opportunities for financial success for care providers. In 2024, providers participating in these models earned more than $1.2 billion in additional payments from our affiliated health plans, reflecting the quality, efficiency, and improved outcomes that they delivered. However, while value-based care continues to demonstrate its potential in improving outcomes and lowering overall costs, these benefits are increasingly constrained by external cost pressures, particularly those driven by recent legislative activity. Importantly, part of the rising cost of healthcare in Connecticut stems from the ever-increasing number of expensive mandates and assessments being enacted, both through benefit mandates and mandates that impose operational requirements or restrictions on health plans. Each year, legislators introduce dozens of bills requiring health plans and insurers to cover specific services, eliminating cost sharing or limiting utilization management, all of which increase premiums. CBIA estimates that Connecticut residents pay an additional $2,085 in premiums due to the state's 68 health benefit mandates. The following legislation enacted during the 2025 legislative session will drive premium increases These include the step therapy mandate, which prohibits certain individual and group health insurance policies or contracts from requiring the use of step therapy for drugs used to treat multiple sclerosis or rheumatoid arthritis. Additionally, the Act makes permanent a prohibition on the use of step therapy for drugs used to treat schizophrenia, major depressive disorder, or bipolar disorder. The biomarker testing mandate requires individual and group health insurance policies to cover biomarker testing to diagnose, treat, manage, or monitor an insured's disease or condition if medical and scientific evidence shows the testing has clinical utility. A state health insurance assessment increase for the function of various state agencies, which are solely borne by the fully insured premium members. While the work of these agencies might be laudable, these assessments continue to grow and are being paid for by those with fully insured coverage. For Anthem, these requirements equate to 5 to 6% of our 2026 premium request. This includes the exchange user fee of 1.58% that is assessed to the entire individual and small group populations both on and off exchange. While Anthem fully supports providing members with access to health care, these additional state requirements drive premiums upward, with the individual and small group markets being the cumulative burden of these increases. Lastly, employers, individuals, and families purchasing health insurance coverage entrust health plans to manage their care and ensure that members receive the right care in the right setting at the right time. Today, vital tools used by health plans at the request of insurance purchasers are under attack. Members of the Connecticut legislature introduced legislation that, while laudable in many instances, make fully insured small group policies more expensive and less competitive. For example, the following bills were debated in the 2025 legislative session: utilization management. Laws and regulations should not impede issuers' ability to conduct reasonable utilization management. Health plans use prior authorization in limited circumstances to lower patients' out-of-pocket costs, protect patients, and prevent misuse, overuse, and unnecessary or potentially harmful care, and to ensure that care is consistent with evidence-based practices. Without these important tools, health plans will be left with few, if any, strategies to effectively drive quality and safety, ensure proper utilization, and rein in unnecessary spending. This will result in employers and consumers bearing the brunt of increased costs through higher premiums. This past legislative session, the actuarial firm Havarti was retained by the Connecticut Association of Health Plans to conduct an independent analysis concerning the healthcare cost implications of Connecticut Senate Bill 10, which would have limited health plans' ability to use prior authorization. The analysis found that the bill would result in significant cost increases for Connecticut residents. A $697 to $907 million annual increase in healthcare costs for all fully insured members, which includes individuals and small group markets, and also a $43 to $64 million annual increase in healthcare costs for the Connecticut State Employee Plan. Benefit mandates. Connecticut requires coverage for 68 specific treatments or services, including some that go beyond evidence-based guidelines recommended by major national health organizations. While the cost of some mandated benefits in isolation may be relatively small, their collective impact drives up the cost of insurance coverage for every person in Connecticut. Often, when these mandates are introduced, legislators acknowledge that they carry a cost, but the impact is typically dismissed as de minimis because it only equates to a 1 to 2% increase. Over the years, the cumulative impact of these mandates imposes a significant financial burden on Connecticut residents, again, adding an average of $2,085 to the cost of every fully insured policy. And prescription drug coverage mandates. Prescription drug prices continue to rise, making drug costs the second largest component of healthcare spending, second only to inpatient hospital. Health plans use several tools to control drug costs while also ensuring consumers have affordable access to medications to address their conditions, including the use of step therapy protocols and formularies. However, in Connecticut, constraints on mid-year formulary changes enable drug manufacturers to raise the price of prescription drugs, driving significant cost growth while restricting payers' ability to maintain and manage these costs. We trust that the information presented during this hearing will assist the Department of Insurance's review of Anthem's rate application. As already noted, Anthem, like all health insurers, is required to have rates that are adequate and not excessive or unfairly discriminatory. We take that obligation seriously. Offering products at adequate rates to cover the underlying risk of the population served is necessary to meet our commitment to our members and ensure market stability. We now welcome any questions the department may have. Thank you.
Thank you, Brandon, and we will move to questions later. Let's switch to Connecticut right now. I'm going to start, Mark, again, if you could introduce yourselves.
Thank you, Commissioner. So good morning. My name is Mark Metter. I'm the president of Connecticut, and by my side is Jeremy Kush. He is from Milliman, the actuarial firm. Connecticut hired Milliman this year to develop and certify its 2026 proposed rates in the individual market on Connecticut's behalf. Mr. Kush, a principal and consulting actuary at Milliman, will provide information and responses to rate-related questions in today's hearing. We both appreciate the opportunity to appear before you to participate in this important discussion on the drivers of our requested premium rate increases and the unique challenges we face in 2026 due to changes in federal law. The main point we want to highlight in today's discussion is that the amounts we pay to hospitals, pharmaceutical companies, and other healthcare providers, along with the utilization of those services by our members, determine the cost of premiums to our members. These costs continue to increase as hospitals, pharmaceutical companies, and other providers demand higher reimbursement for the healthcare services and supplies they provide, and our members' utilization of these services increase, reflecting the ongoing healthcare needs of the people we serve. Connecticut has seen significant provider consolidation in recent years, making contract negotiations more difficult as certain providers gain oversized market power. In addition to these increases in the underlying cost of care, in 2026, our members face the potential loss of the Federal Enhanced Premium Tax Credits, or EAPTCs, to help them afford coverage. We estimate that the loss of EAPTCs would result in many of our healthier members foregoing coverage. For those existing or new members who elect coverage, their rates will need to increase significantly to make up for the loss of healthy members in the risk pool. Mr. Kush is prepared to describe in more detail the effect of the loss of federal EAPTCs in his responses to questions. Ultimately, our filed rates reflect these increased costs and utilization. We have requested rates necessary to continue Connecticut's mission to create healthier futures for our customers and the communities we serve. That mission started when Connecticut was founded in 1981 by a group of physicians seeking to offer a better health insurance option for residents of our state. As a reminder of Connecticut's commitment to the state and its residents, after the passage of the Affordable Care Act, Connecticut stepped forward to become a part of the new health insurance marketplace here in Connecticut. We have renewed that commitment year after year, as some other carriers have dropped out or refused to participate at all. We understand well that for many individuals and families we serve, the individual market is the only option for accessing the health coverage they need, and we take that responsibility seriously. Please now allow me now to address the question of our requested rate increases for 2026. For an insurance program to be sustainable, rates must be adequate to provide for the payment of claims and the costs of administering the program. Our proposed rate increases reflect the healthcare costs of the exchange members we serve. As described above, a primary driver of our requested premium increase is medical trend, which is the increased cost of reimbursing healthcare providers for the services they provide to our members and the utilization of those services, such as emergency room visits, hospitalizations, office visits, radiology, pharmaceuticals such as infusion therapies, and prescription drugs. On the cost side, some health systems in our state have requested that we increase their contract reimbursement by more than the state's cost growth benchmark. As I mentioned earlier, the hospital system consolidation in our state has made these negotiations more difficult. At the same time, Connecticut has always been proactive in managing costs. We work with hospitals, doctors, and other medical providers to help control costs and improve health care outcomes for our members. The rates we have filed reflect the following steps we have taken. We have engage medical providers throughout the state in accountable care organizations and other value-based payment arrangements. We've worked with physicians and hospitals to make decisions based on medical evidence. We've invested in disease and care management capabilities that target members at high risk for chronic conditions with a focus on social determinants of health and the diverse cultural needs of the people we serve. In addition, we have been enthusiastic partners with the state to develop solutions that reduce costs, expand access, and create better health for our community. We have collaborated with the state and the legislature to expand eligibility of the Covered Connecticut program, which leverages Access Health CT to provide no premium, no cost share plan designs for certain low-income consumers who are not eligible for Medicaid. With the likely loss of EAPTCs, this safety net program is more important than ever in keeping Connecticut residents insured. We applaud the state's continued dedication to and funding of the Covered Connecticut program for its lower income residents. We've worked with OHS on benchmarks. I was privileged to participate in OHS's Healthcare Benchmarks Initiative Steering Committee. This committee advises on all benchmark matters, including the primary care spending target and quality metrics. And we've worked with OHS to drive more primary care, to catch diseases at the earliest stage and improve our members' quality of life. Throughout its 45-year history, Connecticut has worked to be a strong partner to our members, the state, doctors, other healthcare providers, and the community. Our parent company, Molina Healthcare, shares a similar origin story to Connecticut, being founded by a physician and consistently giving back to improve the health and well-being of its communities. Molina has a strong track record of participating in public programs and being committed to the goal that Connecticut has worked tirelessly to support, expanding affordable access to health care. We appreciate this opportunity to explain our filing and look forward to your questions. Thank you.
Thank you, Mark. And now let's move to United Healthcare.
Thank you, Commissioner. First off, I'd just like to confirm that you can hear me.
Yes, we can hear you. If you could please identify yourself before you begin.
Yep. Thank you. Good morning. I'd like to start off by saying thank you to the Connecticut Insurance Department for giving me the opportunity to speak today. My name is Mike Dubrowski, and I'm an actuarial director at United Healthcare. I'm responsible for the 2026 Connecticut Small Group ACA rate filing submitted by United Healthcare and Oxford Health. Joining me today is Eric Swain, the Vice President of Sales, and Matt Flood, the Vice President of Network Contracting. Across all our lines of business, we proudly serve 600,000 Connecticut residents. However, this filing and our discussion today are only focused on the small group ACA market, which is regulated by the Connecticut Insurance Department. We are one of 2 carriers that continue to serve in this market. It is an honor to serve 17,000 small group ACA members in the state of Connecticut, and a privilege that we do not take lightly. It is our mission to help people live healthier lives and help make the healthcare system work better for everyone. We work with healthcare professionals and other key partners to expand access to high quality care so members can get the care they need at the lowest price possible. We know healthcare can be complicated, but we are focused on making it simpler for our customers and their providers. We bring together technology, data, and clinical information to serve people, and we work to take costs out of the system and make healthcare more affordable and accessible for all. Today, I'd like to provide an overview of our products, discuss our proposed 2026 rate changes, and explain the major drivers of these proposals. United Healthcare offers a full range of health benefits, enabling affordable coverage, simplifying the healthcare experience, and delivering access to high quality care. We believe everyone deserves high quality health coverage that they can afford. Our coverage options are designed to fit all kinds of budgets. In Connecticut, we offer more than 80 unique medical plans across all metal tiers. All plans are available statewide in Connecticut and allow national access to one of the largest provider networks in the nation. We offer 4 different product types: POS and PPO plans, which allow members to see providers both in and out of network, and HMO and EPO plans, which require members to see in-network providers. We currently serve 17,000 small group ACA members in Connecticut. We understand that there are many options available when selecting a health insurer, and we are very grateful to have the opportunity to serve the Connecticut market. For 2026, we are requesting a 12.9% average rate increase for Oxford Health Insurance, a 12.8% average rate increase for Oxford Health Plans, and a 13.1% average rate increase for United Healthcare Insurance. In recent years, multiple carriers have exited Connecticut's small group ACA market. This is a direct indication of how challenging it is for carriers to remain sustainable in this market. Our proposed rate changes are necessary to ensure that our rates remain adequate. They're vital to our long-term sustainability, which allows us to provide high-quality healthcare to all of our Connecticut policyholders. These rate requests are a direct reflection of the rising medical costs that carriers, including United Healthcare and Oxford Health, face in today's healthcare environment. Although we strive to keep our rates as low as possible to succeed in Connecticut's competitive environment, we must also ensure that rates are adequate to cover these rising medical costs. The biggest driver of these rate requests are historical claim experience and medical trend. Trend consists of two major components. The first trend component is utilization, or the amount of care that is being received by members. In recent years, the amount of care that members have received has increased significantly. We are currently projecting that utilization will drive up costs by 4.1% annually in Connecticut, which is supported by recent utilization experience. Rising utilization expands across many services, but some of the biggest drivers of utilization trend include inpatient medical care, infusion services, radiation therapy services, outpatient surgery, emergency care, and behavioral health services, and behavioral health services, which have seen a significant increase in utilization since the COVID-19 pandemic. The second major component is unit cost trend, which is also expected to drive up costs by 4.1% annually. In other words, members will pay 4.1% more for care in 2026 than they will pay in 2025 for similar services, because healthcare providers are demanding higher reimbursement rates at contract renewal, and pharmaceutical prices continue to rise. Technology advancements also drive up unit costs. Drivers of unit costs trend expand across many services, but some of the biggest drivers include drugs administered at outpatient facilities and skin and mucous membrane agents. The current administration has stated that pharmaceutical tariffs will be imposed very soon and will exceed 200%. This will have significant impact on the cost of pharmaceuticals, which must be accounted for in our 2026 premiums. In addition, Connecticut's healthcare costs are driven up by state health insurance assessments that the Connecticut legislature has passed. These state assessments come with significant costs, which drive up premiums for our members. In 2026, approximately 4.5% of all premium dollars go directly to taxes and assessment fees. This is 44% more than our requested risk and profit margin, which has historically been further reduced during rate review. In addition, Connecticut's healthcare costs are driven up by state policies, including statutory coverage mandates, as well as statutory prohibitions on utilization management tools like prior authorization and step therapy. These policies reduce carriers' effectiveness at properly managing utilization and limit our ability to reduce unnecessary spending. United Healthcare has always been a leader in cost management initiatives, and we continue to focus on driving affordability for our members through a variety of programs and policies aimed at improving the total cost of care. Programs include, but are not limited to, value-based provider contracting, utilization management programs, wellness and disease management programs, and an increased focus on technology and telehealth. Although these initiatives have made significant strides at reducing utilization and unit costs, medical and pharmacy trends remain high. Under the Affordable Care Act, insurers are required to spend at least 80% of premiums on medical expenses and taxes. Under our current rate request, we project that 83% of premium dollars that we collect will be spent directly on medical care. 4.5% will be spent on taxes and assessments. 9.3% will go towards administration and distribution expenses, and 3.1% is our expected profit margin. We feel fortunate to be able to work alongside an insurance department that emphasizes the importance that rates should not be excessive, inadequate, nor unfairly discriminatory. I'm confident that our requested rate filings meet each of these criteria. Finally, I just want to close by expressing gratitude to our members for trusting us with their healthcare needs, and the Connecticut Insurance Department for its continued collaboration and for allowing us the opportunity to address these items today. Thank you.
Thank you. We will now move on to questions, and since I'm here at the mic, we'll begin with me. And if we could bring Michael back up, because I do have some couple of follow-up questions based on his statements.
Yep.
All right.
Thank you, Commissioner.
Clarify, you said a 3.1% profit margin. Historically, certainly since COVID, we have limited profits to 1% or less. I'm presuming you meant risk and profit. Is that correct?
Correct. It's both risk and profit.
Now, looking at the small group markets, you've said, that, or at least the way I heard it, it's barely sustainable, as exemplified by the fact that a number of carriers have left the market, and that you see more headwinds ahead. You specifically mentioned the pharmaceutical tariffs. Are those included in your request? And if so, if the tariffs do not go into effect, does that mean that your requested rate would be greater than is necessary?
We do include an additional 1.7% into our rates to account for the pharmaceutical tariffs. If there ends up not being tariffs, we would actually remove that 1.7%, meaning that we would be able to reduce our premiums. However, when we filed our rates, the assumption was that the tariffs would be around 25% to 50%. More recent information, I guess more recent claims from President Trump have been that they will exceed 200%. And if that is the case, we may need to increase our request even further.
Thank you, Michael. I'm going to turn to Mark now, because you said pretty much the same thing. I want to clarify here, because according to my notes, you said the loss of carriers led to an oversized market power for providers. Is that accurate?
I said that there has been a consolidation, a loss of hospital systems.
So it's
Consolidation
hospital
is-
systems.
Yes.
So how does that translate to price setting? When I say price setting, contract negotiating, are you saying that we are dealing with a small number of systems that essentially control the market? How does it, what's the interaction there?
Yeah, so as a carrier, we have network access requirements. So we have to have enough physicians and providers in our network in order to go to market. And if you have only a few carriers that have acquired physician groups and other hospital systems, it's very hard to exclude them from your network. And that's the real power we get, negotiating power we get, is the ability to exclude a provider if they will not agree to reasonable prices.
Has there been such an exclusion over the past 2 to 3 years?
So we've had a couple of close calls. So there's been 2 significant negotiations. One where the hospital system put billboards up on the highway. But yes, we have gone to close termination on one of them. And for the other one, we were able to come to terms at the last minute.
Thank you. I'm going to turn to Anthem now. And I'm asking specifically about the exchange. And I saw that the current administration in DC has estimated a 5% savings from efforts in 2026 that they say are to eliminate fraud, waste, and abuse. And one example cited was consumers enrolled in ACA plans as well as Medicaid plans at the same time. Do you think this is accurate? And if it is, what would be the impact?
As of right now, we haven't factored that into our pricing. If ultimately that is true, we'll get into our experience and then it will affect future rate filings.
I'm going to ask all 3 carriers if you could each give a brief answer. You've already heard this question. and it has to do with the OHS cost growth benchmark. Now, the adopted benchmark is 2.8% for years 2026 through 2030. And your trend projections for 2026 range from 8 to 10%. Why the delta? What's the difference? And how do we break that curve down so that all participants working together bring healthcare spending below the cost growth benchmark? And whoever wants to go first, feel free.
Mike, would you take a shot at answering that? We can fill in from there.
Yep, I'd be happy to. So first off, as I mentioned, trend really includes two separate components. One is that the unit cost, which we are projecting at 4.1%. And then the other component is the utilization piece, which we are also projecting at 4.1%. The cost benchmark is really, in my mind, aimed towards the providers and keeping the provider requests at that benchmark. However, the utilization piece adds an additional challenge as more and more members continue to use their healthcare. That also drives up cost. So that's one component of it. Matt can probably speak more on the second component, but the other item is, I think we've heard from Mark today with the Hospital Association, is that providers are asking for more than the benchmark, and a lot of that is driven by the fact that they need additional amounts to kind of subsidize the Medicaid and Medicare lines of business. So those are kind of the two major drivers and the two major challenges. Obviously, we have a lot of programs to try to reduce utilization, reduce unnecessary care, things like that. But some of those mandates also make that more challenging as well. So just a lot of challenges that we're facing, and we're doing what we can to keep costs as low as possible, but the utilization piece is a big challenge to keep it under, as well as what we've heard from the provider side.
Thank you. Connecticut?
Commissioner Mace, I can add on to that a little bit. My experience, so I run our network and negotiate the financing with all of our provider partners, healthcare systems in the state of Connecticut. I personally am involved in all of our large negotiations. And my experience as of late is that the larger, highly consolidated systems in Connecticut, the unit price trends that I see are within a reasonable range of the benchmark. They are at times slightly above on the unit cost side, but not materially out of the range. So maybe within a point. The larger, highly consolidated systems have achieved, I would say, rate levels that can sustain generally. What I've seen is a lot of the smaller to mid-size hospital systems that are having, I would say, a more difficult time financially, are asking for larger increases, really trying to kind of get their reimbursement up to the levels of the larger systems, and that is going to be a trend driver in the grand scheme of things. Understanding that the larger systems obviously have the majority of the spend, but some of the smaller community hospitals, mid-size hospitals are looking at the transparency and coverage data, realizing their reimbursements are much lower than the larger, more influential systems, and really trying to push upwards on their rates to keep their financials stable.
And that is a question that I had for you as you spoke. I was thinking, are you saying that the current reimbursement for the smaller, more regional, rural hospitals is actually significantly lower than those for the larger hospital chains?
Generally correct. There's a couple of geographic areas where there is really only one hospital system around. And so there's a couple of examples, and I certainly don't want to name names in the forum here, where their reimbursement levels are at parity with the largest systems in the state. Because without them, there would be a large gap in the market, and our residents, members, people we serve would not have access without them.
Thank you.
Yeah, Commissioner, I do want to correct my last statement real quickly, if I may. You know, we have two networks. And so we have not excluded any of the hospital systems from our main network. We do have a value network where a couple of hospital systems are excluded. So I just want to sort of correct myself on the record there. With respect to unit costs and the cost growth benchmark, Jeremy, you want to comment?
Yeah, absolutely. Thank you. And appreciate the time, Commissioner. So just to echo to some degree what some of our colleagues have mentioned, when we look at the trend that was incorporated into the filing, we do see when we observe the historic experience that the unit cost is generally driving the higher trend. And I do want to make note that when we project forward and what we've observed historically is not only the medical unit cost, but also we've seen that pharmaceutical drugs, both from a utilization standpoint and also a unit cost standpoint, are generally increasing more than what we've seen within the cost growth benchmarks.
Thank you. If utilization increases are not bad or good, they depend on whether or not people need care. But if the unit costs are increasing and those are not supported, or those could be lower, that's something that we as a state need to look at. And let me go back to the same questions I asked both the pharmaceutical PCMA and the hospital association. In some states, and we all talk, we try to figure out what works and where. In some states, the AG has the ability to review individual contracts. And we've heard from the AG significant concerns about how these contracts are structured or not structured. Would you support giving the Attorney General the ability to review individual contracts? And do you think giving the Attorney General that ability would result in lower unit costs? And that's for everybody. So we'll start whoever wants to go first.
So I'll jump in here. One of the really nice parts about Connecticut and its regulatory scheme is that we're not overburdened by filings. So I don't know that having additional review of the actual contracts will help that much. But you can make some specific rules regarding contract provisions. For example, there are some contracts out there that may have a requirement that you pay the contracted rate, even if the billed rate's lower. So you could pass a rule that said you have to pay the lesser of the two. There are other contract provisions that also are concerning. And I know, the state has done that already with some contract provisions, and I think they could do some more of that. But I think just a pure, review of all the contracts, I think that probably is not the way to go.
I agree with that commentary. I would say that, the transparency data that is submitted does give very granular details on the rates that are offered hospital by hospital. So I think that's a great place to start. I would also say that additional discussions around how to mitigate out-of-network costs, if we are not able to achieve a reasonable rate structure with a hospital, could protect our members from cost and also protect the overall cost of care in Connecticut. So I think perhaps additional discussion around mitigating out-of-network costs could be beneficial.
Yeah, and from Anthem's perspective, I would echo some of the comments that came out of some of our other counterparts here. For me, it's a little bit different. I think a lot of this comes down to there's a whole new population of folks that are utilizing benefits today that have not been historically. And specifically, as you look at things like Covered Connecticut, where folks have access to free healthcare, zero cost share means you can pretty much go wherever you want, whenever you want. No limitations as far as what they're going to be spending out of pocket. For me, it all comes down to education. So I think whether it's the insurers, the hospital systems, government, I think collectively we can probably do a better job of educating the consumer as far as what their options are in order to get them to higher quality providers at a much lower cost.
Thank you all, and I will now turn it over. We will continue with the CID questions. I'm going to turn it over to the person to my left, our Chief Actuary, Assistant Deputy Commissioner for the Actuarial and Data Science Divisions, Wan-Chen Chu. Wan-Chen.
Thank you. Thank you, Commissioner. I think that today we have a lot of the very good discussion and question from our commissioner, and then we also have additional comment from others. So I'm going to just talking about who are reviewing the red filing this time and some of the standard we have to follow through. And then after that, I'm going to pass it on to our two actually here review this. So so far is in the CID here, we have two very good and experienced health actuary, Tricia to my left, and then Sarah the next after. And they have been very involved in reviewing the red filing and the red filing from all the Anthem, Connecticut, United Health, care has been reviewed, and then they have discussed all the question concerned with me. And after my remarks, Sarah will take the lead in asking some questions have not been addressed yet regarding major component contributing to the rate change request in a few minutes. And Tricia will follow with additional highlight if needed. As mentioned by many of you and agree on, our filing review process require timely review and each filing consideration feedback from today's meeting. And the only standard, as Commissioner indicates, under the law we can use is to evaluate the rate requests must not be excessive, inadequate, or unfairly discriminatory. And our actual rate review consider historical and project experience, medical and pharmacy trend, retention assumption, and other actuarial federal state mandate company solvency and other actuarial factor. Specifically, the CID actual review, all red filing comply with the actual standard of practice, as many of the actually familiar with, that's the ASAP 41 for communication and documentation, the ASAP 23 for the data quality, and ASAP 25 for credibility, ASAP 13 for trending procedure. And we also consider the cost growth benchmark from OHS and complete a very thorough review. And we also like to thank you for our carrier here who have been kind respond to all the questions from our actuary, and so that way can speed up the review process. With that, now I would like to ask Tricia and Sarah to conduct some technical discussion. And Sarah, why not you go ahead?
Thank you, Chen. I'm Sarah Mu, the health actuary at CID and the primary reviewer of all carriers filing for 2026 rates. We have a few questions for each carrier. Please provide quantitative measures and be as specific as possible with your response. I'll start with Anthem individual segment. Regarding the covered Connecticut program within your individual filing, please state any pricing impact adjustments for this block and how you arrived at the impact figures.
Can you repeat your questions again? I'm sorry.
This is concerning the covered Connecticut program. You can give a brief description of your understanding of the program, the impact of this program on your individual block of business. Concerning 2026 rates filing, please provide a brief description of any adjustments you made in the rate build and how you derived that number.
Thank you. So the Cover Connecticut now has been in place for several years. So we do have the data reflecting our experience. So when we start out with the claim cost, which is a cover without cost share, the states would pay for the cost share that Anthem pay for the members, and the state reimbursed that to Anthem. Anthem reduced the claim cost by that subsidies that the state reimbursed for Anthem. On top of that, there is a utilization fees because now the cost share are paid at $0 amounts. So there is an extra utilization due to that. Right now, Anthem make the assumptions that since the increase in the utilization, at least for the existing members, is already reflected in the data. So Anthem make an assumption that the states will only pay for the new members coming in. We actually have a significant increase in our covered Connecticut population. With that assumption, Anthem did not deduct the 2.5% utilization fees from the states. So based on that claim experience, we would project it forward. One thing that does have an impact on our rates development on top of the utilization fees and also the cost share that we receive from the states is the increased population of covered Connecticut. Technically, they are on an 87 CSR and 94 CSR. That ultimately increased the civil loading because now there's a lot of members on that 87 and 94, so we have to making sure that we account for that cost.
Thank you for your answer. The second question, the company has included a 3.7% mobility impact that will need to be applied to the rates in the event of enhanced subsidy expiration. Please provide the justification for this estimate.
So since the expiration of the enhanced subsidies, the members have to pay more of the net premiums. So what will happen is healthier members will drop out. And the high-risk members, they know it pretty well what kind of conditions and also what kind of healthcare they're going to utilize. So they are more likely to remain. So based on the lab assumptions that we have is roughly 20%. That's what we have a lab assumption. Within that lab assumptions, we have more healthier members dropping out, and then the high-risk members are more likely going to stay in. On hindsight, actually, the 3.7% seems to be very aggressive. Based on some of the data that we have, it could go as high, based on our sensitivity analysis, it could be as high as like 13%. So one thing that we do make an assumption is since the states subsidize for the covered Connecticut population, we assume there's no impact on that population at all. And then on the flip side, where members do not receiving any subsidies today, those members are more likely going to remain in the individual ACA.
Thank you. This question is regarding the quantitative measure, if you could provide. Please provide a brief description of all the Connecticut and federal legislation passed or finalized this year that would impact 2026 rates, but are not included in your pricing initial filing, since the passage or finalization was after your rate filing submission. Please list each item separately and provide the impact on 2026 rates.
So when we submit the rate filings, there was legislation out there that was passed, and due to the timeline constraint, Anthem did not reflect them in our rate filings. There were three things that we responses in our questions. The one that have an impact, which is the biomarker testing. And that's the impact that we did not reflect in our rates yet. It's around $1 PMPM to be exact. It's a 96 cents PMPM.
Do you have anything to add for the step therapy?
The step therapy, we did evaluate that since the step therapy is only narrowed to 2 conditions. So we assume it has minimal impact on that one.
Thank you. The very last question concerning your individual segment is, can you verify that there are no additional changes to the rates regarding the federal legislation that is finalized in July?
We did not reflect any additional costs in there with the exception of the expiration of the enhanced subsidies.
Thank you. Moving on to Anthem's small group segment. We only have one question concerning this segment. So please explain any expected changes to morbidity and the risk adjustment between the experience period of 2024 and the pricing period of 2026 due to the changes in small group market, such as the exit of Cigna.
So for the risk adjustments, what we did to estimate for 2026 was we do have the risk adjustment by different metal level. And because the distribution between 2024, which is the base experience, versus a 2026, there is a big mix changes. For example, we grow a lot of members on Gold Plan. So what we did was we reflect the mix of memberships that we project for 2026, and that's how we get to the 2026 kind of risk adjustments estimates.
Thank you. Appreciate your answers. I'm going to move on to Connecticut individual segment. The first question is regarding the Covered Connecticut program. Within your individual filing, same question. Please provide any assumptions and adjustment building 2026 rates and how the actuarials arrived the numbers.
Appreciate that. Thank you. Similar to what was previously described, the Covered Connecticut program has now been in place for several years. So as we develop our rates using an experience base based on calendar year 2024 information, that data, that underlying claim experience already includes some of the Covered Connecticut claim variance. So based on that, we trend that forward. And to your point, we do incorporate the 2.5% scheduled savings that reduces our rates slightly. But the induced demand, again, based on the additional utilization of experience, the lower cost sharing or the zero cost sharing that we observe is built into the experience. We do expect that based on the rate changes and the rate request that has been submitted, similar to what other carriers have observed, that there will be some disenrollment and a potential shift in our mix and our underlying silver plans and silver variants. So we do expect a slight mix change for 2026. And that equates to about a 5% increase that we build into our premium rates.
Thank you. The next question is, you estimated an increase to the underlying claims for about 7.4% if the enhanced subsidy expires. Please provide the justification for this estimate.
Absolutely. So we do estimate about a 7.4% increase to the underlying claims with the enhanced subsidy potential expiration at the end of 2025. That is largely due to understanding that right now current enrollees that are above 400% of the federal poverty level that do get some federal subsidy premium tax credits, that subsidy will completely go away for those enrollees. So we expect that the majority of the disenrollment will be above the 250% of the federal poverty level. So those who do not qualify for cost share reduction plans. So we assume a higher disenrollment for those enrollees. We do expect that with the disenrollment, which currently our sensitivity testing in our model estimates anywhere between potentially 24 to 32% disenrollment within the marketplace between 2025 and 2026. Again, based on our sensitivity testing, we do expect that based on that, as was previously discussed, the people who will choose to disenroll based on the removal of these tax credits will likely be healthier members of the population, people that don't necessarily need the coverage, which means that with a smaller risk pool, you will most likely have higher morbidity enrollees that are retained. So based on that, we estimate about a 7.4% increase.
I appreciate that. Please provide a description of all the Connecticut and federal legislation that passed or finalized after your initial filing. List each item and provide the impact on 2026 rates.
The primary legislation that was passed is at the federal level that we expect to potentially have an impact in our premium rates. And that is related to the One Big Beautiful Bill Act. There's an increase in the Medicare physician fee schedule proposed within that bill. And we estimate that to equate to about 0.5% of a potential increase based on contracts being attributed to a percentage of Medicare. So that is the primary piece of legislation that was passed after the filing of the rates that actually will have an impact. We did review some of the state legislation you mentioned earlier, the step therapies. And again, we expect that that will have a minimal impact. So the primary legislation that will have an impact on the rates is that physician fee schedule increase.
One last question. Please verify that there are no additional changes to the rates with the state legislation that is finalized in July.
At this point, there is no additional change to the rates based on that legislation.
Thank you. Moving on to United and Oxford. This concerns their small group segment only. Mike, can you hear me okay?
Yep. Good morning.
Thank you. In the filing, the company stated that to account for uncertainty regarding price changes by manufacturers due to economic policy changes, mostly notable on pharmaceuticals, a total price impact of 1.7% is built in the rate filing. Would you please provide an updated view on this subject and let us know if you still stand by the 1.7%? Will you have a renewed view on the impact?
Yep. Thank you, Sarah. At this time, we are still using the 1.7% and going forward with the 1.7%. When we developed this estimate, we were assuming that the tariff percent would be 25%. At this time, and more recently, President Trump has provided numbers that are significantly above that 25%. And if that is the case, that tariffs do exceed 25%, we may need to increase our tariff estimate. However, at this time, we are sticking with the 1.7% impact that we filed.
Thank you, Mike. Second question. Please explain any expected changes to your morbidity and risk adjustment between the experience period and your pricing period due to the changes in the small group market, such as the exit of Cigna.
Yep. Thank you, Sarah. At this time, we have not made any adjustments for morbidity to account for Cigna's exit. Our assumption is that although Cigna has lower claim costs than the statewide average market, they do have higher payments into risk adjustment. If the risk adjustment program is working appropriately, those should balance out. So at this time, we are not including any additional item for morbidity with their exit.
Thank you, Mike. That concluded my questions to all carriers.
Are there any additional questions, Wanchan? No. Thank you to the actuaries for all the work you've done, and thank you to all the presenters. We do view this as a critical component of the process for companies to be able to clarify for the public the rationale supporting their requested rate increases. Now, at this point, I think we are going to take a short break. I think we're right on track. We're going to break here and we will resume at 11:15 a.m. We'll see you in 10 minutes. Please take your seats. Please take your seats. We are about to begin.
Please be seated. Please be seated.
Thank you all. Let us resume the program. We will begin. Everybody, could you please take your seats so we can resume the program? We will begin with questioning from our fellow state agencies and the exec and the Constitutional Office of the Attorney General. And if I could ask Tom Ryan, Assistant Attorney General, to begin. Tom?
Thank you, Commissioner Mays, for hosting this rate information hearing, and thank you to all of the parties who are participating today. The Attorney General has submitted comments and a letter regarding the rate filing. I would like to explore a few of the issues highlighted in his comments. The first of which relates to the impact of provider upcoding on the experience you all have submitted as the foundations for your requests. Our office is receiving an increasing number of complaints about provider upcoding and the lack of support from insurers to address this issue. The concern we have is that unchecked upcoding inflates the value of your experience and thus undermines its credibility. As the Attorney General mentioned in his letter, experience cannot be credible if it is inflated by upcoding. So the Attorney General provided 3 examples of upcoding in his comments, which I will reiterate for purposes of our discussion. Example 1, a patient presented at a hospital emergency department with non-life-threatening symptoms. She was seen briefly by a physician and released without further treatment. The hospital billed a 99284 CPT code reflecting a level of care that is a 4 out of 5 measure of medical severity, with 5 being the highest. Example 2, a patient visited a hospital-owned freestanding urgent care center located on a commercial street far away from a hospital campus. The hospital submitted a claim to the insurer with an emergency department revenue code reflecting an emergency department place of service, when in fact the service did not occur within an emergency department. Example number 3, a patient attended her annual physical and was questioned by the physician about a fully resolved injury she sustained while in the care of another physician years ago. The physician submitted a claim to the insurer for an office visit in addition to the 100% covered preventative services, on the basis that the question about the fully resolved condition from years ago constituted a separately billable significant additional service to the physical. In each of these cases, consumers were told by their insurers that they cannot alter or investigate the code submitted by providers, and that it is up to the patient to convince the provider to submit different or lower level codes. What, if anything, do your companies do to address these types of upcoding situations? And I'll, Anthem, maybe start with you.
Yeah, sure. I can address. So in scenario 1, and I had to get a little help from my provider relations folks, just me being in a sales background, but the response that I got in more detail was, we emphasize the importance of precise billing practices and have established a comprehensive review system for both emergency department visits, which include 99284 and 99285, which represent level 4 and level 5 medical severity. We thoroughly assess various factors to ensure their appropriateness. For the professional component, our team scrutinizes the diagnosis codes linked to the visit. These diagnoses guide the medical decision-making expected from providers, and we benchmark these against other emergency department providers to ensure consistency and accuracy. On the facility component, we examine the resources utilized during the visit as detailed in the claims. This ensures the resources align with the diagnosis codes and confirms that services are rendered based on legitimate medical needs rather than inflating claim severity unnecessarily. So if our review indicates that a claim level has been coded higher than warranted, we would adjust the reimbursement level to be deemed appropriate. Providers would then have the opportunity to contest our adjustments by submitting additional medical records.
So you would downcode the claim?
Essentially, yeah. And then if the provider disagrees, we would request the additional medical records to go from there.
Okay. I will say example number 2 is an Anthem example.
Yeah, and that's
what-
the physical physician with the office billing.
No, that's the place of service emergency department for an urgent care center.
Yeah, so we'd be happy to talk about more specifics. Again, I got the response back late, so we were just trying to get, our ducks in a row with the provider response, but we'd be happy to follow up with more additional details at a later time.
Okay, and if you ever do an audit or you find down the road that somebody is overcharged, do you not only seek reimbursement from the provider, but do you also have the provider reimburse the patient who has paid too much?
We would in those cases, as long as it's an in-network provider, that's part of their contract, I believe, for the most part. Again, not a provider expert here, but at the end of the day, I've been involved in situations where if a provider were to overcharge, we would intervene and react appropriately and get in contact with the provider so that the member is reimbursed for anything they overpaid.
So would you agree, though, that if your experience reflects upcoding that is unchecked, that it would actually be too high?
I'll defer to you on that too.
If that is the case, it's true. However, from an Anthem perspective, we do want to be competitive in the market, so we have to ensure that we appropriately reflecting the level of care. For example, our rates right now, both on individual and small groups, are the lowest in the market.
Okay. United?
Yeah, thank you for the question. There's a widely recognized stat out there that up to 25% of total healthcare costs are attributed to, considered wasteful spending.
So upcoding per se?
We take it, I'm sorry?
Upcoding per se, or is that what you're talking about?
Upcoding would be an example of that.
Yep. Okay.
This broad bucket of, wrong side of care, upcoding, fraud, waste, abuse, all those things. We at United Healthcare take that seriously. We are often recognized as the most thorough payer. I mean, we do the most thorough job to make sure what we're paying is accurate and appropriate. We have a global bucket of things we do called payment integrity to make sure that things like upcoding are addressed. We're always addressing everything from a, pre-claim, when we receive the claim, prepay to post-pay. We'll make sure that everything is as appropriate as possible. You mentioned the emergency room situation with upcoding. We have something called EDC, the emergency department. It basically analyzes, is this the right level of care? So we'll look to see, was it really, in our opinion, a level 2 and they charge a level 5? And if they do, we'll pay at the level 2. So we'll make that assumption that we think it was a level 2.
So do you do that do you do that when the claim comes in? How does that work? And how does that protect the consumer who might have a deductible?
We'll do it when we're processing the claim. That system takes, looks at it before it's paid. If that claim gets adjusted, then the member cost share is based on that adjusted amount.
Can I ask you this too? Because again, these people said that their insurers were non-responsive. Does the consumer have an appeal right to an upcharged claim? Since it's not technically denied, these people did not get an appeal right. So I'm curious as to whether you would consider that an appealable issue.
I'm going to start the answer. I may not exactly answer the question. We have an advocacy program where members that call in, if they have a dispute between what was paid to the provider or how the provider billed it, our advocates can help with that situation. In some instances, they'll call the provider on their behalf to ask that claim was coded appropriately.
But it's not a formal appeal.
I don't know. So the question is, if the ER coded it as a 4 and they think it was a 3, can they appeal that? I don't know that. I might have to get back to you. That might be more of a member to the provider, but I'm not sure.
So would you agree though, if you're paying upcoded fees, that actually impairs the credibility of your experience?
Again, I would contend that we're not paying those upcoded fees. Like we're running, for the ER example, we're running it all through that program. And
So you think you've got a handle on all of that?
we think we do. We think, again, we've been recognized by a number of actuary firms as the most thorough payer on all those things.
Okay, thanks. Connecticut?
Yeah, so I can count at least 4 programs we have at Connecticut to try and review claims for upcoding and for other inappropriate billing practices. So we have both electronic programs. We also have a special investigations unit who can look at improper coding if we think there's some, fraud going on. So those programs, catch these issues. If there is, an outlier, we certainly will work with people to try and fix that. There are times when a provider just bills incorrectly. They bill for a gallbladder when it was a spleen. And so at times the member is going to have to go back to the provider and say, hey, there's this mistake in your coding.
So you won't do an outreach to the provider of
Not always, because again, we won't know necessarily that there was just a clear error by the provider. If there's a provider who's billing outside of standard billing practices, that's when we can see it in the data.
So that's more of a pattern thing than an actual. So
But-
that's why I asked you about the
yeah,
appeal,
sorry, excuse me.
the right to appeal, because if somebody gets a right to appeal, they formalize your review. Whereas if you're not seeing a pattern, you're saying to them, hey, and this is what we've heard from people, just go to your provider, have them change the code, which is almost impossible for a consumer to do because the provider doesn't want to do that. So, it's they're between a rock and a hard place, and it seems like not only are they getting billed too much, but so are you. So like, shouldn't you be channeling or encouraging those kinds of, assessments that you'd get through an appeal process of whether that's happening out there in the real world, and who the people are that are committing those upcoding?
Yeah, we do that. So we have both a systemic way to electronically go through claims that are submitted to see if there's upcoding going on. We also have, again, manual processes through our SIU, our Special Investigations Unit. So we're doing what you're saying. Again, there can be outliers there where a member may have to go back to the provider if there's just something, clearly wrong that the provider did that's just a simple error that we wouldn't necessarily catch, again, like billing for the wrong procedure.
Yeah, I have a feeling though that, and again, we receive a lot of complaints. The kinds of these examples that we've iterated here resonate with people. Because people go for physicals and they're like, oh yeah, my doctor said, he asked me about my headaches, and all of a sudden I got an office charge. That is so common a complaint. And it's not just that those people are paying, but so too are the plans. And we've not seen any interest in putting a check against that either by the health plans. So like, I think that's something that, you should be taking a closer look at, because it's definitely happening. So, yeah, go ahead.
Oh, please.
Sean King from the Office of the Healthcare Advocate, and this is just to piggyback on that a little bit. Because we heard about in contract negotiations, price is one of the factors. It's probably the biggest factors that's discussed, and that impacts trend and all of these things that we're concerned about, and then in turn increases premiums. But price isn't necessarily the only way that especially the larger health systems and folks like that can ensure greater revenue. So to piggyback on Tom's line of questioning, does it come up in negotiations that there would be limitations in certain situations, or whether it's upcoding, whether it's utilization management, are there negotiated limitations on those activities that would
in turn limit the reductions in revenue to the providers? I hope that question made sense to everybody.
Mr. King, thanks for the question. I would say one example of where that could occur would be with the emergency department claim analyzer. So that is something that we do to make sure that the level of reimbursement for an emergency room claim, to Mr. Ryan's point, is clinically and medically appropriate. There has been examples of larger systems wanting to remove that ability from our agreement. And, you know, as I am negotiating these agreements, I do my very best to preserve the integrity of the relationship, and which means keep them in my network, but also preserve that type of a program in order to keep my ability. But there could be a scenario where that ability could be removed from an agreement through a negotiation, through leverage. I also just want to just kind of talk and add a little bit on about we do really strive to try to keep the member out of these situations. We have what we call a pre-claim review of coding, where we offer the ability of a provider to put the coding into a system to see how it's going to adjudicate, to see whether they'll be paid for the way they're going to bill it. We also have a prepay review that we do. So before the claim is paid and the member's benefit is calculated, we do reviewing of the coding for appropriateness. And then if something has kind of got through, there are post-pay reviews as well that we do. So it's a multi-pronged approach. You know, we try to do all these reviews in a way that is not onerous and administratively burdensome, understanding that the hospitals also have administrative pressures. So we really try to get after it with 2 steps before a claim is paid, and then a potential step after a claim is paid to try to do it right if it's missed. As was mentioned before.
Yeah, thank you. And just to be clear, before others answer the question, I'm not just focused on upcoding. This applies to utilization management programs, broad scale audits of large batches of claims, not just individual ones. So that's the context of the question for others who want to answer.
Yeah, and I'll say from the second part of your question, the provider piece of it, I'm not familiar with. We'd have to follow up, and I can get back in touch with you when I speak with our provider relations folks. But going back to some of the upcoding questions, we did introduce a policy in 2024 that actually includes a detailed review of claims where there's a wellness visit and a problem-oriented evaluation and management service attached to it. So our provider relations folks will review those cases to identify if it is truly a newly diagnosed chronic issue or if it's something that was a previously diagnosed acute condition. And in those scenarios, we would potentially look at the billing and reach out to the provider to have them adjust those types of claims, or simply flat out deny any additional codes that were included as part of their preventive visit.
Just to bring that back to my original question, though, but does in Anthem's contract negotiations, and then Connecticut as well, does it come up? Is it discussed whether certain limitations are placed on those types of audit activities, claim review activities, those types of things?
Yeah, my assumption is yes, but I would have to confirm with my provider relations team, so I can do that for you.
Yeah, and it usually comes up in the context of if we're going to make these certain decisions, they would like to have some say in it in some sort of internal appeal process or some sort of a process with the hospital systems. We resist that approach because we need to have our consistent prepayment and post-payment upcoding practices and review.
So I don't know how much time I have left here, but I have a few things I wanted to get to. There's been some discussion here about the cost shifting from government plans to commercial plans, and it's the assumption is, without actual clarity, that the government plans are underpaying. Do you think it would be helpful not just for the legislature to assess that question, which is probably where it needs to be assessed, but also for the health plans to know from hospitals what their actual costs are in bringing services and goods to their patients? And by that I don't mean their bill charges, but would it be helpful to include that, say, in the charge master so that when you guys are negotiating with the hospital systems, you have transparency, you understand how much they pay for an aspirin. Would that be a thing that would be helpful to legislate?
So I would say, the more information we have going into a negotiation, the better we can negotiate hospital contracts.
I would agree with that. More transparency there is, we would be for that.
Yeah, similar response for Anthem. We're open to dialogue and obviously would welcome further conversation on that topic.
How does the hospital association feel about that?
I think we would be open to a conversation about that, but whether we would support anything like that really depends on what's revealed through the process.
Thank you. So just a question about the benchmark. So Anthem dismisses the OHS healthcare cost growth benchmark as inapplicable to healthcare premium rates in its actuarial memorandum. We are present in the place where that benchmark was enacted. Please explain to the commissioner and the legislative representatives here why you do not think it is applicable.
The metrics for the benchmark are based on the median incomes. And when we develop the pricing trend, we need to align to the actual standard of practice. So when we develop our pricing trend, since our block, particularly individual and small groups here, they are credible. So when we develop our trend, we are based on experience of those blocks and come up with our projected trend that go into our pricing. Versus the median income is far different than what indicate the healthcare costs. So that's why.
Does Public Act 25-94 change that evaluation? I don't mean necessarily from an actuarial point of view, but from just a basic rate filing point of view.
I mean, Anthem will definitely try to hit the target benchmark, but at the same time, we have to abide to actuarial sound practice. For example, the adequate rates that we have to abide to. So we do have actual standard practice that we have to follow in order to develop our rates. So just based on the median income would not be a good practice when we develop our rates.
So do the other health plans agree with that assessment? And further, do you think that there will be a shift as a result of the new enactment that gives the commissioner the ability to reduce rates when there's a failure to meet the benchmark?
So Connecticut worked on the benchmarks. We're supportive of the benchmark. We think it's very helpful to have the benchmark in our negotiations. It provides a nice guidepost for us when we're dealing with the hospital systems. And so while they're important, at the end of the day, we have to have adequate rates. And so, we will continue to file adequate rates, which is actually a statutory requirement. So we're already doing what we can do to reduce rates, and we'll continue to do that.
Okay, I think maybe Lloyd, you can take over now.
So thank you,
Mike?
Tom.
Oh, sorry.
Did you have any more questions, or was there somebody else waiting to answer?
I thought Mike was going to answer for United. Mike, if you're there.
Yeah, I can. I would just echo Connecticut's comments and Anthem's as well. We are under a set of rules as actuary, and we need to make sure that our rates are adequate, and that's what we do.
Thank you, and thanks, Tom. Next, we're going to hear from Boyd Jackson from the Office of Health Strategy. He is the Director of Legislation and Regulation.
Thank you, Commissioner. And I'm going to pick up in the same place talking about the benchmark. Totally understand that the benchmark is looking at the affordability of care. And we approach that with measures of what residents can afford. So looking at median income and the state gross domestic product. And you all are doing your actuarial calculations, but you're projecting trend. And as AAG Ryan has emphasized for years, you all play a role in setting the trend. You're part of the negotiations that determines the prices that then go into the trend year after year. So I want to talk about affordability from that perspective and what the policies are that are going into place to adjust the trend for future years. We know that affordability is important. We showed data last year from a survey that 46% of residents are delaying or foregoing care due to cost. So, affordability clearly matters. And we've heard some of that today. We've talked about economic principles, so I'll throw in a couple of, I'll name a couple that have been discussed. We've talked about the potentially expiring enhanced exchange subsidies. And that brings us to the intersection of price elasticity of demand. There's number one. And adverse selection, number two. We've heard a lot from Connecticut about the potential there. And that's that as the price increases, you all have articulated that you expect some of the healthier people faced with the rising cost will drop out of the market, and it'll leave a resulting population in the market that is sicker. We've heard 3.5 to 7.4 additional percent increase in rates. And I think, Connecticut, you can correct me, I think you said you're estimating 24 to 30% disenrollment.
That's based on internal Milliman studies of the Connecticut market. That's sensitivity testing, yes.
Thank you. So that was all related to potentially expiring exchange subsidies. I'm wondering if you all do similar calculations for what the rate increases themselves are doing to affordability and people falling out of the market. And in light of that, I'll ask each of you, in light of that conversation, leaving aside the actuarial assessment, do you believe your rate increases as proposed are affordable for the residents of Connecticut? Anthem.
I mean, the honest answer is it's subjective, right? I mean, not for what's affordable for one person is not going to be affordable for another one. I think that's the difficult position that we're in, and the challenge that we're having right now is how do you make it affordable for everyone, right? So part of our hospital negotiations, and I mentioned this in my opening, was to drive value-based contracts. I think that's where we have to start. Like I said, we've been doing this for the last 10 years. We are seeing incremental growth and positive change come from these value-based contracts. I think we just need to get to a place where fee-for-service is completely obliterated in order to make sure that people are getting access to value-based care where they're getting positive outcomes at a lower cost. Like that's really what we have to get to the crux of the problem. And we all have to do that together. It's not just the hospital systems. It's not just the carriers. It's not government. We all need to come to the table together and figure out more innovative ways to do that. I had mentioned a couple times in some responses that I had, I think it does come down to education. You have a lot of uneducated folks accessing care. It's a complex system, let's be real. It's very difficult to navigate this healthcare system that we have in the United States. Specifically here in Connecticut, it's just as difficult as it is anywhere else in the country. So I think we really need to do a better job of educating the consumer to let them know what is out there, what's available to them, how they can access lower cost points of care, higher quality points of care. Like that's really where I think we need to get to.
Just a clarification, you asking for small group and individual, was that just for both? Yeah, okay, so I thought. I agree with Anthem's comments. I think what we're trying to do is put more options out there for members to select from. So those costs are going up. We know it's difficult and we're focused on affordability, and we get that that's difficult to drive affordability. So we're trying to bring options out there with new plan designs that give members the opportunity to make better decisions, get lower out-of-pocket costs if they do so. So we're, I think we're very much aware of the pressures on the affordability side of the members.
And I agree with the other carriers here, but I do want to say subsidies do play an important role in Connecticut, both federal and state subsidies in allowing people to afford coverage. So, we certainly would advocate on continued funding of Covered Connecticut, that program. And we think there is a role for subsidies in the marketplace.
And then another topic that's been explored several times are what we've heard about Medicaid cross subsidization. And we presented data last year. I don't have a slide with me. We talked about the extensive variability across hospital reimbursement rates. And one of the explanations that we've heard today and that we've heard in the past is that it's related to the Medicaid cross subsidization and Medicare. But when we looked at the chart, there was no discernible correlation between the percentage of patients who were on government payers and the reimbursement rate from commercial payers. That is, some of the hospitals who had the lowest share of Medicaid patients had the highest commercial reimbursement rates, and vice versa. Some of the hospitals who were seeing the greatest share of Medicaid patients had the lowest commercial reimbursement rates. So the variability doesn't seem to be explained by just the cross subsidization. Certainly we could run regressions and see what those look like, but I'm wondering to what extent that comes up in your conversations, or is it just a post hoc explanation for why things are going up? How is that presented in your negotiations with the provider community? And that's for each of you, so take it in whatever.
Yeah, I would have to defer and get back to you, just not having my provider relations rep here, but happy to have a further conversation and get some more detail for you at a later time.
In my negotiations, I have heard that expressed as a concern from hospitals. And I think it echoes the comments from Mr. Schaefer on the Hospital Association.
Yeah, so it comes up all the time in the negotiations. It is a statement that's made by hospitals. And, it sort of depends on the hospitals you're dealing with. Whether this balloon theory is real or not, also depends on how much revenue the hospital needs for whatever they want to do, whether they want to build urgent care centers or grow. They want more revenue, and it's hard to get the revenue from the government program, so they have to go and get the revenue from the commercial payers. So it does come up.
Is that a winning strategy? I mean, they're telling you this stuff, but is it actually causing you to pay more? Because I mean, I've heard about this as an issue since 1998, right? Do you guys actually pay more as a result? Are you subsidizing the government programs? And I guess the follow-up on that is, why isn't the democratic process being triggered to alter those reimbursements if it can be proved that they're undervalued?
I would say the gentleman from the association, I think, said it did.
Well, I guess my first question was, are you actually paying more? Are you persuaded by that argument to the extent that you actually pay more, a larger increase to offset the underpayments that are being claimed?
Just to give you an answer here on that one, I think it's on a case-by-case basis. If there was a particular hospital that was, significantly adversely impacted by either not receiving an increase to a particular government line or a decrease, they would bring that up in the negotiation. I certainly would give a lot of counter arguments and facts and data-based answers to that to push back on it. But I think in a situation where a particular hospital was more largely adversely impacted, it would create more pressure in that negotiation that could lead to an out-of-network scenario, or just a situation where perhaps we have to send out letters to members, which we hate to do, advising them that we're in a negotiation where we may or may not reach agreement. So I think it's hospital by hospital, case by case.
I guess I just wonder, how do you actually even evaluate that claim, right? So if the hospital's saying, Medicare and Medicaid don't pay enough to cover our costs. Essentially, that's what they're saying, right? And that you, commercial payers, have to pay more as a result. How do you know, if they're not disclosing their costs, whether Medicare and Medicaid is meeting their costs?
My personal approach would be to look at a resource like the American Hospital Directory that would show the government reimbursement and the margins that the hospital is making. And that would give me data points to use in my negotiation with the hospital system on whether there's any reality to that claim.
But is that granular enough to actually answer that question, though?
I look at it top side. I think additional granularity could be helpful to understand, back to our point around transparency on charges.
Okay, thank you.
Yeah, I think probably everyone in the room and online has been in negotiations and knows that it's a multifactorial back and forth. They're going to provide a lot of reasons that they need higher rates, and you're going to provide a lot of reasons that you need lower rates. And I think that part of the question here is to what extent is each one of those being dug into? So we've talked about the Medicaid, government cross-subsidization. Last year, we talked a lot about quality programs and differential payments based on quality. Something that was talked about a lot last year, has been brought up several times today, was inflation. And I think that, probably grabs a lot of people because we experience inflation, across the board. But medical inflation is significantly lower than general inflation right now, at least. In 2024, in the Northeast region, consumer price index inflation was 2.2%. From June to June, 24 to 25 was 1.14%. So can you help us understand a little bit about what we're seeing in inflation right now and how much that factors into your rates, and just kind of help people understand the nitty-gritty of that, and not just say inflation, which I think everyone has an immediate emotional reaction to because we've experienced inflation over the last few years, but it doesn't seem to show up in the numbers as much.
Hey, Mike, if you're there, you want to take this one?
Yeah, I can try. I think the word inflation was maybe used more by the health plan or the hospital association than us. I think we have talked a lot about trend, and I think we've gone into quite a few details about how the cost of care is not really just inflation type thing. It also takes into consideration utilization and how much members are using care. And that has significant impact. I think I mentioned earlier that's 4.1% of our trend right now. It's just the fact that a lot more people are using their care than they have in the past. And then on top of that, I think the other part that we've mentioned in quite a few details right now is the unit cost. And that's really driven by the contracts that we have with providers. I think I mentioned earlier, there's technology that drives up some unit costs, but really it comes down to the costs that we're paying for hospitals, for pharmaceuticals, and a handful of things. So
like I said before, that the pricing trend has to be based on experience, and I can give you an example. Cover Connecticut, because of the Medicaid redetermination, we have a big chunk of members coming in for Cover Connecticut, and since there's no cost share for that population, we see a significant ER utilization due to that. And Brendan was talking about education. That population is very challenging to reach out and convey the message that there are the alternative that they can go to instead of an ER. Their ER are definitely double the non-cover Connecticut population. Drug is not a category that they are high utilizer. and also mental health services are a very high trend for that population. So to me, if we somehow just change the behavior of that population, instead of go to the ER, go to the physician office or something like that, that would be a significant savings there.
So, just to jump in and answer the question from Connecticut. We talk about inflation in our contract negotiations. We talk about CPI, we talk about medical CPI. So we use that as well as the cost growth benchmark to try and get the best deal we can for our members. Do we know the exact cost of a CT scan machine and how that's allocated? No, we don't have that level of granular detail. But there is some other information we have, Jeremy.
Yeah, I just want to point out to Mark's point, and as was discussed earlier by the other carriers, we certainly appreciate the general inflation that we see, within the broader market. But at the end of the day, as was described earlier, we do need to, from an actuarial and a pricing standpoint, take a look at the underlying data that we have, which is going to be a combination of the cost of the service as well as the utilization of those services. So as was noted, to the extent that members may be choosing to pursue higher cost care, that is something that is included in the underlying data, and that is something that we need to account for as it relates to our pricing. And just as an example, when we think about both the cost benchmark, we think about the underlying inflation trends. What we see within our historical experience, even going from calendar year 2023 to 2024, for medical and prescription drugs combined, we saw about an 18.7% increase in underlying costs. And that's attributable, again, both to a unit cost, just price increases, as well as utilization increases. So obviously that is certainly far exceeding the cost growth benchmark as well.
Thank you, Boyd. Now let's move on to the Office of the Healthcare Advocate. And we have with us the General Counsel, Sean King. Sean?
Thank you, Commissioner. And I just have probably 2 or 3 questions that weren't covered by my colleagues already. If they trigger anything else, gentlemen, please join in. We heard a lot of comments about the activities that the insurers engage in to put downward pressure on prices, to push back on upcoding and things that are going to overall increase prices, increase the costs, increase premiums down the road for your members. But there was a comment towards the beginning of this hearing about how the MLR sort of disincentivizes insurers to engage in some of those activities, right? Because you got an MLR, in some ways, there's only one way to grow your business, and that's by increasing the premiums. And if you're going to do that, you have to increase the amounts that you send out in medical claims. It's a general premise. Do you agree with the notion that there is, and again, not to suggest that you're completely disincentivized from pushing back and trying to do what's best for your members, but do you agree with the notion that there is some disincentive, maybe some reason to maybe not push as hard in those negotiations as you otherwise would if you were getting the benefit, the insurers were getting the benefit of those lower prices or those increased utilization management activities?
Yeah, so I'll jump in here if I can. So I've never understood that argument. I don't think it holds water. First of all, you have to have MLRs under 80 in the individual market to really take advantage of that argument. And our MLR is much higher than that at this point. So we have a clear incentive to get our prices as low as we can. We have a competitor in the room, and we want to sell more product than they sell. So that has never been a factor. I've never heard anybody in the industry say that, and I've never understood that argument. So,
yeah, I agree. We're in a competitive marketplace. We're in a business. We're in a free market, and the higher our rates, the less membership we get. So our incentive is to keep drive affordability, keep our rates as low as possible, and get as much market share as we can to help the Connecticut marketplace.
Yeah, ditto for Anthem. I keep stressing this. I said it last year. I'll say it again this year, next year, and forever. Value-based care is where we're going to find the most bang for your buck. We have, risk involved there. So does the hospital system and all of our providers. So at the end of the day, having those shared risk arrangements, I think, is where you're going to find out, all right, we're both in this together. We need to both figure out a way to bring these costs down. So I disagree with the incentive piece of it as well.
I just want to have any of your companies ever rebated, given an MLR rebate to members ever?
Yeah, I could speak. Yes. Yep. Every year we go through a process that
In Connecticut?
I'd have to look back at at all the data, but
I have to say I've never seen one.
Across the country. We certainly have.
Yeah, and I can speak a little more on this as well. I think it's very unlikely in Connecticut that we pay a rebate, and a lot of that's driven by the fact that we have such low risk margins in this market. We are filing this year MLR of about 88%, and we're required to pay if we are below 80%. That's a huge gap that we would have to see with claim costs. Now, I can't speak on the history if this always ever happened. Obviously, during COVID, there was some very low claim costs that may have driven some of those numbers down a bit. However, the MLR calculation is based on 3 years. And given our risk margins in this market, it is very, very challenging to hit those MLR requirements because it is just a market where it's hard to make money, frankly. So.
Yeah, Connecticut has not paid a rebate in the individual market.
Yeah, and I do agree with United on this one, because we have a very low kind of risk margins in there. The chance for us to get there is very low. Unless you have situation like the COVID years, like in 2020, other than that, it's almost impossible to get there.
Yeah, just a minute. Oh, too, I think on the small group side, you guys did pay. You did have a payout. I don't think it was this year, but in the past, that was maybe due to COVID, not on the individual side.
I think I agree with you. Yeah. Like I said, unless you have a COVID years or something like that, and then we would pay out. But other than that, I would say it's almost impossible.
Shifting to the loss of the enhanced premium tax credits, I think everybody had sort of a significant shift in morbidity that they're using to factor in the changes in membership that might occur as a result of those lost premium tax credits. Is it, I guess, not being an actuary, number one, is it appropriate? And if so, did you, and what extent did you use the enactment of the premium tax credits, which wasn't that long ago, to compare your analysis of what your assumptions are going to be in terms of changes in morbidity? Did you see is that sort of an opposite change in morbidity from what you saw when the enhanced premium tax credits were enacted? I saw Mr. Wen shaking his head, so I think you understand the question.
Yeah, we did look at historical data where when the enhanced subsidies passed, we did see a significant growth in our memberships. On top of that, we see the Medicaid redetermination. So whenever you have more subsidies and the net premiums that the members have to pay reduce, we definitely see membership growth from there. So if I remember correctly, the entire market for Connecticut, it used to be around 100,000 members. As of right now, I believe it's way over like 150.
And were those, I understand it's probably not a mirror image, but were those changes in the morbidity close historically?
Yes, and so when we passed, yes, we do see a stable in the market when the enhanced subsidy passed. During the Medicaid redetermination, actually the opposite is happening. What happened is when the members drop out of Medicaid, they have to make the decisions to move to ACA or not. More likely, the healthier members are drop out and go uninsured, and then the high risk members stay in the ACA market. And I think one of the piece that you see is carriers did not price for that, and they actually take a hit on that. And you probably heard in the news that nationally a lot of carriers are underpricing because of that.
Is that consistent with the other carriers? Same response?
I would say that what we've observed in the market is potential for historic underpricing based on the market changes that have occurred over the last several years. I think just to very quickly go back to your original question, we also, when estimating the potential morbidity change related to the expiration of the enhanced subsidies, we also did take a look back, going back to when the subsidies were first enacted, but also understanding and appreciating that when those subsidies were first enacted was coming off the tails of the COVID-19 pandemic. So we also took a look back a little bit further down to 2019 levels from both a population and a morbidity standpoint as we assessed the changes that we expect to occur going forward with the expiration of the subsidies.
That's, I think, just related to the individual market, which we help participate.
My last question actually is for Mr. Hallmeyer. I can find it here. Drug companies a lot of times will argue that the high prices they charge, especially when something initially hits the market, is necessary to recoup their R&D costs and to incentivize further research on other new pharmaceuticals. There's some research out there that exists that suggests that that need is overinflated and that those high prices are far too high to recoup those costs and incentivize more R&D. Is that something that your organization also finds, the PBMs also find and push back on when you're negotiating drug prices, rebates, that type of thing?
Thank you for the question. So it depends on a drug by drug basis. Now, what I mean by that is if there's a drug that has no other competitor whatsoever, PBMs aren't as effective in negotiating rebates. In fact, there's rarely ever a rebate on a drug that does not have any competition. So now with drugs that do have competition, we can pit those, we meaning the PBM industry, can pit those manufacturers against each other to negotiate those discounts. We don't have insight to the R&D process or how much it costs to go through the FDA process. But we do question it sometimes, the numbers we do see out there. In addition to that, we see commercials, literally every commercial break on drugs. We think that is part of the reason why drugs are so expensive, to pay for those as well. I don't think there's one thing that we meaning the PBMs can point at why it's priced so high, but we can speculate a few of those things.
Are there any policy changes that legislators or others could make that would help shed some light on that?
I can follow up with it, but anything we can do to increase competition would be something I would suggest.
I don't have anything else.
Thank you, Sean. Tom, one question?
We're not at 12:15.
Go right ahead, please.
Might as well use up our time, right? Given that when insurers pay separate facility and professional fees, costs for services are substantially higher, why don't your companies negotiate lower single rates with hospitals under circumstances where hospitals employ all the providers and staff in a provider-based office, thus alleviating the need for two separate fees?
One example would be attempting to contract global in case rates, which we do as often as possible. We've also, I believe facility fees have been cut out of the reimbursement structure in Connecticut.
Not,
So-
not entirely. They're
Not yeah.
for certain types of codes. That's true, but not all.
I think there was mitigation there, but really global contracting, case rate contracting would be the strategy we would employ to try to bundle the entire reimbursement in the system into a particular service to mitigate that.
Yeah, I mean, the reason I'm asking is because traditionally the reason that there's been a need to have professional and facility fees in hospitals going back probably 100 years is you have providers coming in that are not employed by the hospital that need to be reimbursed separately. When you have one entity that owns the facility and employs all the people in it, why is there any reason to have separate fees?
I agree with that. And again, try to find ways to mitigate that wherever we can.
Yeah, I would have a similar response. Would be welcome to further conversation with our provider relations folks and explore additional options there. But as of right now, I don't have any further response.
Yeah, I agree with my colleagues over here.
Do you know whether you've attempted to negotiate single rates ever in those circumstances? I mean, facility provider-based services have been around for probably 15 years where they're separating those fees out for offices, right? These are not on hospital campuses. They're doing evaluations and things like that are kind of office-based. The state has been trying to address that. It has limited reach because it can't touch Medicare, but it seems to me, again, that if there's no real reason for separate payments, why would you do it? The law doesn't say you have to, right? So.
Again, I agree, and I can follow with examples of where we've attempted to. I don't have a great specific example to give you right now, but I know that we've worked to go global in instances, but I can work with my team and follow on that question.
I think that's it. Thank you.
Thank you. And now we will move to our elected officials from the legislature. We will have the co-chair of the Insurance and Real Estate Committee in the House, Representative Kerry Wood, who will have the next 10 minutes. Representative?
Hi, thank you for being here today. My name is Kerry Wood, and I'm the co-chair. I'm here with a bunch of members from the Insurance and Real Estate Committee. To my left is Representative Tom Delnicki, Ranking Member Senator Tony Wong, and also the Chair of the Commerce Committee and a member, Representative Stephen Meskers. We work very bipartisanly, and all ideas we put on the table, and we're really focused on trying to find the best environment for insurers to thrive and to provide the best quality care to our customers here in Connecticut. We got into the weeds a lot, so I want to kind of just talk a little bit on just kind of a person-to-person level on what the legislature's role is and who we regulate. So we regulate the fully insured market, and these are plans on the Affordable Care Act and some individual and small group plans. So that's about 400,000 people. Is that correct? Anyone know the exact number? 224,000? Okay, so we're here talking about 224,000 people. I don't think a lot of people realize that. In fact, today when I was having coffee at a local diner, someone came up to me and said, "Hey, my insurance rates are about to go up 20%. And he works at Stanley Black & Decker. So all over the news today was everyone's health insurance rates are going up. What we're here talking about, 200,000 people. I also want to ask a few questions, and a lot of this was answered, so I'll fast forward through this, but like, what are the other factors besides utilization and prescription drugs that impact premiums? I heard the insurance fund assessments. I heard health and operational mandates, and we have those numbers at our fingertips. In fact, OHS just put a report out February 1st, 2025, that our frozen formulary mandate costs $10 to $18 million a year. Just putting that out there. But I do want to talk about the participation in the cost growth benchmark. Is that a cost that is being passed on to consumers, or do the carriers pay for that out of other costs?
I'm honestly not sure I know the answer to that question. I would have to follow up and confirm for you.
Yeah, I would love a confirmation from that, because I think a lot of the times we have the best intentions of forming all these working groups and boards and commissions and cost growth benchmark and stuff. And at the end of the day, the goal is to lower costs of insurance and healthcare. And in fact, we are creating a larger bureaucracy that is not getting to the bottom of what we're here trying to do for the 200,000 people. The legislature has also tripled the amount of people on Medicaid in the last decade. So we just heard from CHA about the pressures of over a third of our population being on Medicaid and what pressure that is putting on the commercial plans. So this little amount of people, just think of how much pressure is going on the costs of these plans when we triple the amount of people on Medicaid. I want to ask just a generic question of some things that passed, which was we passed an affordability factor this past session, and we just heard from the commissioner that the department is limiting profits to 1%. And I want to ask, is that a state that you want to do business in? Like if you weren't in Connecticut and you saw those numbers, would you say, hey, I want to go to Connecticut and sell plans there? Anyone?
Well, that's one of the reasons why for small groups, you see only 2 carriers out there.
So that really concerns me. I am extremely concerned with Harvard Pilgrim leaving and so many carriers leaving the small group space that we're going to have no one left. And we're here talking about affordability and rate increases. I'm worried about having no carriers left in this space. So I want to talk about the things that our committee has done to try to lower costs, create competition, and provide better outcomes. We have proposed a reinsurance plan at least 3 years in a row. I'm looking at my colleague, Senator Wong, because this is something he's been passionate about. We also tried to pass to limit clawbacks for mental health providers from 18 months to 12 months, because we hear a lot of that from small businesses that are just trying to provide. We heard from everyone that mental health services are going up. Well, if most people are spending time doing administrative work rather than providing care, that's adding cost. We did pass a bill through our committee to limit the amount that is being passed on to our insurance fund. And for everyone that doesn't know, the insurance fund is over $100 million a year to pay for state agencies and other services that is being passed on to the users of these plans. We also passed, we tried to pass association health plans while we're here talking about the individual market. We also heard a lot about competition, and association health plans would allow small businesses and nonprofits to pool together and purchase insurance like a large group. We also proposed to reduce the premium tax to encourage competition and allow more carriers to enter the market. Recently, we passed a flex rating bill for property and casualty, which allows mid-year rate adjustments. Why aren't we doing that for the health insurance space? We also proposed direct enrollment from the carriers so that when people that you are doing business with are not on your plans, you can directly enroll them. We also passed out of our committee a mandate review, which would give us a cost benefit analysis of the cost of the mandates. As we've heard, Connecticut is the most mandate rich state. There's a major cost to this. We've heard the 2016 CBIA study had us at over $2,000 annually. None of these things passed, all the things that I just mentioned. These are all the things our committee has been working on. and not a single one of them has passed into law. I do also want to just talk about consolidations. We have heard that consolidations are driving up cost, and we have approved consolidations, most recently being Nuvance and Northwell. And this continues to happen, but we have less hospital systems and less competition in the hospital space. So, you know, I really want to thank the carriers that are participating in Connecticut. I want to do better as a legislature. We are trying to do the right thing in terms of looking at the insurance fund, in terms of looking at mandates. But I also want to look at the positive, because if you take out the mandates and if you take out the insurance fund, we're actually doing a pretty decent job. If you look at the surrounding states, our costs are not as high as some of the other ones in terms of in the chart that was up here. I think it was the first presenter. We are still lower than some of the other states. So if you take out some of those big costs that are driving up these premiums, we're actually doing a pretty decent job, but we're not able to see that because of how we're leading. Lastly, I do just want to say that we did put some great ideas forward today in terms of insurance fund assessments, in terms of mandate review. The other thing I heard was having hospitals come before us for rate reviews. So we have all shared the things that will work and address this. And the committee is committed to working on those. We need help getting them across the finish line, because we are certainly trying every single session to get these things passed, but are not able to get things that will address costs across the finish line. So thank you for your time.
Thank you, Representative Wood, co-chair of the Insurance and Real Estate Committee. And next, we will move on to Ranking Member Senator Tony Wong.
Thank you, Commissioner Mays, the Department of Insurance, and for conducting this meeting in this legislative office building, for transparency and accountability. And this is being covered by CTN, so it's really important for people to see this. And I want to echo the sentiments offered by the chair of the committee. And truly, it is bipartisan. I think Democrats, Republicans, independents all agree that our healthcare costs are unaffordable, unsustainable, and frustratingly for many people. And I'm going to channel many of the voices that aren't able to speak today. I'm going to channel that this is truly, for the past 10 years for myself being here, we continue to raise rates every single year. So, and in the past years, we've had engagement and challenged all of you how we can do better. And I know, as the good chair articulated in the Insurance Committee, we have tried. I want to acknowledge the administration as well as the department. But I am channeling the voice and the frustration of so many of our consumers, constituents, and your ratepayers, that one, that they can't afford these kind of increases. And unfortunately, I'm also channeling sometimes the anger that they have as a result of the frustration. One, the affordability, but I think sometimes when their loved ones and their employees and themselves are in need of healthcare coverage, they run into the bureaucracy and the insensitivity of treating them like a number. So the combination of unsustainable rates, inadequate customer service in their most critical moment of need for their loved ones and valued people, you're not there. But here we're talking about rates. So I'll get right to the point on that. But I felt it was really important. I'm not here to beat up our insurance companies. I want to thank all of you for appearing here today. You didn't need to be here. You're here, and I'm grateful. And we want you to stay in the state. We want you to provide healthcare coverages for our constituents who need it, because unfortunately other companies have exited the state. That being said, I think I have a couple questions that I wanted to pop out to the various members that are here. Your rate increases right now is an average for individuals of 17.8%, higher or lower, and for small groups to be 13.1. If you mentioned it earlier, and I was not here to hear it. Please excuse and indulge me. Would the federal budget changes impact your potential rate considerations? And have you considered that in this proposal? Or would you be coming back to this committee, to the Insurance Commission, and to the legislature? You don't come to us, but be able, with that consideration, to ask for a further increase in light of the potential impact of the budget?
I'll defer to our actuary who's on virtually.
Yeah, thank you. I can speak briefly on this. A lot of the subsidies are more on the individual side of things, and we are in the small group market. So those don't hit us. The one thing that does hit us and hits us pretty significantly is the pharmaceutical tariffs. I've mentioned before that currently we're assuming that the tariff rate could be 25%, and that has 1.7% impact on the overall rates. More recently, President Trump has made statements that they could be 200% or even 250%. And then when you're looking at 250%, that's 10 times what 25% is, and the impact would be significant, obviously, due to that. And if that is the case, we will likely have to request a new rate request. So that is one that really hits us pretty hard.
Anthem, Nick?
The enhanced subsidy is the one that is going to have a significant impact on the rates. If Congress pass and extend the enhanced subsidies, and then the rates would be lower. However, based on what we are today, the timeline is very tight. Unless we pass it very fast, other than that, we have to assume that the enhanced subsidy has to stay. Going away.
Similar to the other carriers, the expiration of the enhanced subsidies, as has been discussed, is going to be the primary impact to the rates. That those values and those estimates were included in the initial rates, or at least the initial rate filings. One piece that I do want to mention, as was discussed, related to the Budget Reconciliation Act, since that was passed after the original filings, is there's a provision in that act related to an increase in the Medicare physician fee-for-service fee schedule. And to the extent that the fee schedules are increased, we estimate that to have an impact of about 0.5% on premiums.
So I'll speak in common parlance. If everything is in effect as we know it now, you could come back and ask for additional rate increases. Yes or no?
It's already in our rate filings. We do have an option where we give a factors in there. If the enhanced subsidy is going away, here's the factors applied to that. If somehow Congress pass and extend the enhanced subsidies, we also have an option for that out. The guidance from the department was we file with the assumption that the enhanced subsidies will stay.
Thank you, and I'm sensitive and respectful of other people's time. The second question I have is, we've talked a bit about pass-through costs from the standpoint of private payers to different marketplaces and the Medicaid marketplace. I'm going to put a little pivot on pass-through. So very similar to this process, I'm familiar with it for over 10 years, is you present your actuarial analysis based upon your healthcare cost delivery, right? You present the numbers, you present the cost of contracts, even though unfortunately we don't get to see your contracts. And I respect that there may be proprietary aspects, but nevertheless, we don't always get how you get to that number, but you present it and we trust you relatively. And the commission makes that decision, but they don't have a lot of leeway in regards to saying, you present the actuarial numbers, we're going to say we're going to reject it, right? You have to pass that through. And to me, it kind of reminds me of a lot of similarity with another unaffordable, unsustainable, and unbelievable rate increases that affected consumers and our electric utilities. Electric utilities undertake the same process. When they request a rate increase based upon their purchase of energy, they pass that through. Our regulatory authority, PURA, can only consider what you present and then pass that through to the consumer. There's no leeway. So that's how the process works. Would that be correct? As I understand it, right? Unless it's anything different I miss. Okay, then I'll continue the second part of the question. But you have passed through business costs in owning PBMs, in other businesses. And when I look at Wall Street benefits and stock dividends, when I look at executive compensation, and many people feel that way too. And then you come and say, we don't have the money. Somehow, some way, something's missing on a pass-through cost. Why are your cost of doing business as a whole and your profits not considered in your rate request consideration? Please explain to me why that would not be considered beyond the fact that's the way the guidelines have been driven. I said the same thing to electric utilities. When you're making millions and billions of dollars on the consumer's pocketbook, but at this and paying out excessive or highly valued compensation packages. I'll take back the word excessive. While at the same time, the consumer that are paying your bills are struggling to put food on the table, struggling to make payments on the challenges that they have. Why are we not considering all aspects of your benefits and profits in all of your businesses when you're considering rate increases? And if it may be a legislative policy to consider that, then perhaps the insurance committee can review that. But please explain to me, you the commissioner, any of you, why we don't have that pass-through consideration. When you've articulated that when we increase and reduce Medicare, there's pass-through to cover in your business operations. So feel free to all answer that and give me guidance as a policy advocate to say, maybe we want to look at your entire book of business when you consider rate increases.
Yeah, so on behalf of Connecticut, we don't own a PBM. We don't own providers like some of our competitors do. So I think we're in a bit of a different grouping there, but I'll let my colleagues talk on that point.
Yeah, I'd start by saying, we get a very small margin on our business. We heard, 1% for this business we're talking about today. I think, our earnings come from scale where we have a lot of business across the country. But again, our margins are very thin. If you look at the other business entities that our organization owns, that's, part of our effort to try and gain more savings by integrating those processes and being more efficient on those things. So I think that's what we're trying to do. If we own a PBM, that PBM has to stand on its own, and it does, and we sells to other companies as well. But for us as one entity, we're hoping that the PBM and us can be more integrated and deliver better savings.
Yeah, and too, correct me if I'm wrong, but I mean, administrative cost is built into our actuarial submission and rate filing anyway. So I mean, there's an element of salary, overhead, everything else that goes into running a business that gets included into our rate filing. It's just one piece of it, obviously, at the end of the day. But
it's an interesting comment that was made, is that your PBMs are separate books of businesses. But I don't see that on a 10K report. I don't see Wall Street reports that they're separate business entities. You report your profits and loss based upon your entire book of business operations. So again, it's a conversation, it's a thought, but I must share with you, and I'll close by respecting other people's time by simply saying this. As a legislator representing our constituents that we hear from and are in this building to represent, I'm here to give them a voice, and I want to thank you all for being here. But nevertheless, you need to hear them. They're at their wits' end. They're frustrated. It is a very difficult choice between buying health insurance versus putting food on the table when it's become unaffordable, unsustainable. And I think we all need to do far better. And when you compose that picture of Wall Street large S and executive compensation while people are making ends meet just barely. There's an inconsistency. And you can see how the emotion can boil over when their loved ones are denied care because an AI or a policy review rejects them as a number, not as an individual. So perhaps it's not even an issue of rate review. Maybe your customer service reaction can be a much more sensitive, that when people call you, it's simply not because they want to say hello. When they're calling you, looking for review on their cases and insurance approval, they're doing it because they're at their wits' end. They're at critical healthcare needs. So perhaps your customer service could be a little better in understanding the unique challenges of the people that you serve and pay these prospective premiums in order to have that coverage. So thank you, Commissioner. But I think I posed some very difficult questions to you in regards to how business is done. But let me close by simply saying this. Business as it's been done before cannot continue. It is unaffordable, unsustainable, and to many people footing the bill, it's unbelievable. Thank you, Mr. Commissioner.
Thank you, Senator. And at this point, we will take a short break. We will be back in roughly 20 minutes at 1 p.m. Please be here at 1 p.m. Thank you.
She's not young.
Well said, Bolton.
She's the brain.
I'm very impressed.
Wow.
I'm working with, Mike Nico. I've been working insurance issues around, particularly with, there for the last 5 years, huh? I actually engineering. Yeah.
Oh, awesome. Thank you.
I have 3 engineering degrees. I'm well versed in Six Sigma, certified in Belt. I've got a EIT from Maine. Got CPM from the ISM. And I've worked for GE for like 30 some years. Just spent wow.
Please take your seats, everyone. Please take your seats. We will resume in 1 minute. Welcome back and thank you all. Now we will begin the public comment portion of the meeting. For some housekeeping, when speaking, please begin by introducing yourself and please address your comments directly to me. To ensure everyone gets a chance to participate, please focus your remarks on the pending health insurance rate filings that are currently under review by the CID. We will begin with elected officials who will have 5 minutes, followed by members of the public who will have 3 minutes to speak. And Allison is doing a yeoman's job over there keeping track of who's signed up and who's not. And she tells me that Representative Tom Delnicki is the first elected official. Tom?
Good afternoon, Mr. Commissioner. You know, I think we first met in 2017 at a health care meeting just like this at the old G. Fox building on the rate increases. And I have to tell you, you haven't aged a bit.
Come back anytime, sir.
I think now I get 10 minutes, right? So I have to commend a colleague of mine, Senator Wong, with some of his comments there. But I don't think he went far enough. And I have to ask this rhetorical question. What is health insurance for? It's for the patient, for the person, for the individual. And when we talk about it and we visit the campuses where the CEOs are, and you realize it's a business. And it shouldn't be a business because it's all about saving lives. It's all about the quality of life. It's all about doing what's right and what's good. And it's interesting. I actually took a look at the bottom line on a few of the companies, and I saw Anthem Health at $5.98 billion with a B. I saw another company, I think it's Elvance, and that was 176 billion with a B. And it struck me. That is a huge amount of money. And you've got to wonder exactly what that represents and what the CEOs are making. Because to me, it's all about the patient. It's all about the person that has to go to the hospital, that has to see their doctor, that has to find out that they've got high blood pressure, much like myself from time to time. And that's what it should be about. It should be about people, about the individuals, those that every day need to have that care. And many a time they can't afford to have that care. And that's wrong, just plain wrong. Now, I'm not pitching for single payer, but what I am pitching for is tightening the reins, holding accountability as a moniker, because these folks don't need to have these expensive corporate headquarters. I don't begrudge them for that. But I do say every 95 cents, 99 cents should go to the patient, should go to the doctor, should go to making someone healthy, saving a life, and someone having a good quality of life thanks to good health care. I don't challenge the doctors. They do a great job. I had an accident last year in Hartford Hospital. The doctor that treated me did a great skin graft. But again, what are we here for? We're here to make sure that we have good health care, good hospitals, and people are taken care of. So, Mr. Commissioner, that's what I have to offer here. I think that when I look at 14%, 21%, and 26% as the individual on exchange rate increases, I'm shocked. It shouldn't be that way. So thank you for the opportunity. And I have to admit, you look great. You look equally as good as you did in 2017, the first time I ever attended one of these meetings. Thank you, Mr. Commissioner.
Thank you for your kind words, Representative. Let me just turn and look around the table. Would anyone from either the carriers, the hospitals, or PBM care to respond to the representative?
We share your passion to help people live healthier lives, and we wake up every day trying to do that. I think you've heard a lot about the different cost pressures that are going on in the industry right now, and they're very difficult, and they can't be solved by any one of us alone. So I think we're all trying. I think you heard a lot about how we're trying to work together to do that. But we agree that healthcare we need to make it as affordable as possible.
Thank you, Eric. Appreciate that. Our next speaker,
Representative Pavlok D'Amato has her hand raised on Zoom.
Representative, please join us.
Thank you, Mr. Chair and Commissioner. And I just want to add, I know that the chair of the Insurance and Real Estate Committee had mentioned earlier that minus the mandates and the insurance fund that we are doing pretty well. And I have to agree. I just want to remind people who are at the table and those watching that I was looking up SB 10 the other day, and that was another example of, even though we're here and we say the same thing every year when it comes to these rate increases, we then go back to the table and we do the same thing. We have these mandates, and looking at SB 10 and the amounts, granted it was on the original bill, but the amounts that those would have increased, these very plans that we're now complaining about, is astounding. I couldn't believe those numbers, and it really took a lot of negotiation and hard work on different individuals' parts to get some of the language changed so it wouldn't have that impact. So while I appreciate everybody's contribution, if we could then remember this come February when we are voting and co-sponsoring bills that have these gigantic fiscal notes on them, because I'm going to be going right back to this, to this conversation, because again, we keep doing the same thing, saying we're not going to do this and not cause increases, and then going back during session and voting on and supporting bills that end up increasing the costs. So thank you again, Mr. Commissioner, and everybody for their help and their participation today. Thank you.
Thank you, Representative. And I know you've been on all morning listening to this. We do appreciate your involvement. And in case I don't think I mentioned it at the start, but the representative is a ranking member of the Insurance and Real Estate Committee. And with that, let me move to, I think it's Representative Steve Meskers now. Steve Meskers, your turn.
Thank you, Commissioner. I want to echo the group in thanking you for your testimony. I appreciate you are the bearers of bad news, which are the numeric numbers of the rate increase. And I'm appreciative of the issues of the cost pressures in the providing of this service. But what I would ask from the insurance carriers, which would be helpful going forward, there were comments from the commissioner and related to transparency in relation to pricing, and whether it was the commissioner or one of the other maybe healthcare strategy. If you don't have all of the strength and the power of legislation for transparency and negotiations or contract transparency, there are things we can do legislatively with the proper guidance or hold hearings to consider legislation that will improve that price transparency for the negotiated process of getting to rates. Because right now, with all due respect, there's a good relationship in the room between the insurance companies, between the hospitals, and between the pharmaceutical companies. And in framing it out for my public, or the public in general, my premium represents $1 I put on the table, or $1,000. Or lately, I guess, Mr. Commissioner, we're at 34,000 or something for a family of 4. The insurance premiums that are going to go out every year are going to be split in a maximum amount that's going to go up 5%, 10%, 12% a year. And there should be at some level friction between the insurance companies, the PBMs, the pharmaceutical companies, and the hospitals on where that dollar is expended. And the transparency needs to be at some level higher and a little more friction in the negotiations. And if we need to help you on that, I think you can count on the legislature. We want to do the best we can on cost containment. One of the other measures in testimony about informing and educating consumers, I can tell you, personally, I don't think I've been anesthetized more than 4 times in my life. So most of my interactions with my medical providers, I've been vertical and coherent. I don't think I've ever been challenged on a coding. I don't think anyone has called me and said, these are the codes we got from your last interaction with your provider. Are you happy? Were those procedures followed? I don't think anyone ever said, hey, Mr. Meskuz, we can reduce your copayment by $5 or $10 on your next 2 visits if you're willing to engage in this survey about the coding, if we're having problems with coding. I don't think there's ever been an incentive structure to engage the consumer, our constituents, in their health care. We sit there and the only point is of services the copayment and trying to decipher a bill. If someone who's worried, if there's issues with coding and someone approached the consumers and the consumers were offered that alternative or that incentive, the cooperation, the feedback loop might be interesting. I'm not sure if we're finding the problem, which I'm hearing, and I'm particularly concerned with the Affordable Care Act, with what's going on with the tax structure and the incentives. I'd like to see what we're doing about emergency rooms and what proposal that we could help enact through insurance or through commerce. Are there incentives that we can, without compromising health and the outcomes, are there incentives we can provide to try to reduce the amount of emergency room visits to provide better healthcare outcomes? We're willing, I guess I'm from the government, I'm here to help you, probably makes you all shiver. But there are probably things we can do structurally to change outcomes to the better. So those kinds of ideas and thoughts should be presented to us. We would like to be willing partners. This is still the insurance capital of the world. Our interest in the success of the industry is tremendously high. But we're going to need that level of cooperation to get to the outcomes. At 12% a year, I think it's 6.8. I was trying to check my calculator. 6.8 years, that will double the premiums. At some point, this will not be a private market unless we resolve the issues of cost containment. We're going to go to a single payer at some point if insurance goes to 48 or 50 or 60,000 a year for a family of four. None of the corporations will want it except for their executives. People will need a recourse. We're going to have to figure out if we can get the costs under containment, under control, and all I can ask is for your cooperation. And I won't be as blatant in my compliments, but I do want to compliment the commissioner. And I want to thank all of you for being here today. Thank you.
Well, I do want to tell you, you all look great. I'm happy to have you here. Any response to what the representative has said?
So just on behalf of Connecticut, Representative Meskers, especially on our emergency use issues and emergency room issues, we have several ideas and would love to work with you.
Yeah, sorry, I was going to say I would echo those comments. We're actually about to go into a full court press, especially in our individual segment, on a marketing effort to really start to educate, especially these covered Connecticut folks. But as soon as you started speaking, I had, probably a billion ideas popped in my head as well. We just need to do a better job of educating these folks. You can't really mandate it, obviously, unless there was some sort of legislative action. Maybe that's what we need to start talking about. But just quick off the top of my head, it was, if you're going to sign up for an individual plan and you're new to the market, you've never had insurance before, maybe you're new, whatever the reason might be, why not have a test that says, hey, this is where you go to the emergency room and this is why, versus here's where I can go to my primary care physician. Like things like that. I think we can come up with new innovative ideas together collectively, everyone in this room, to help get that word out there and hope that people really grab onto the fact that there are alternative options. Just because you see a hospital downtown in Hartford doesn't mean that that's where you have to get your care. There are other alternatives that people can obviously take advantage of. So I think, we're all thinking the same way. It's just a matter of actually doing that. I'm sure all of my competitors up here have programs within our suite of products that do that. I know we have a smart shopper program as an example, where you can shop for services that say, hey, go here, not there. This is going to cost you less. It's going to be a lot more convenient, things like that. I do think there's a lot of weight and merit in doing things like that. So yeah, I would love to collaborate with you guys on some additional incentives and alternatives.
And I would just add, we agree, we can't keep doing the same thing. Our fastest growing plan nationwide, and just rolled out here in Connecticut, thanks to some law changes that allowed us to roll it out, is a plan that is completely different than what we've done in the past. In the past, we've had deductibles and co-insurances, and when you go get care, you have no idea what you're going to be charged. You have no idea what the cost is going to be. You have no idea what your out-of-pocket's going to be. It's confusing. This plan tells our members upfront, via a very simple app, what the copay is going to be. No deductible, no co-insurance, just a copay. And the revolutionary part of that is we can now steer people to the place where they're going to get the highest quality, most efficient care upfront. And we can do it via that copayment that they can see. And when they go and get that care, the cost they pay is that copayment. They're not going to get 50 other bills that they weren't realizing were going to happen. So things like that, I think, are changing how healthcare is evolving, and will help with this idea of members know what they pay up front and can make better decisions up front. It'll help things like that, upcoding and things like that, because they're going to see up front, I go here, it costs me this, I go there, it costs me that, and they can make those decisions. So that will help educate the members.
Thank you. And Allison, are there any other elected officials who have signed up to speak? Wonderful. So that brings us to the end of our list of elected officials. So now we will open it up to the members of the public who signed up to testify. As previously mentioned, please state your name, limit your testimony to 3 minutes, and address your testimony to me. Allison, could you please proceed with reading the list of public speakers?
Jan Kritzman.
Jan?
Good afternoon, everybody assembled here today. My name is Jan Kritzman. I'm from Newington. I am a 13-year breast cancer survivor. For your information, Connecticut has the second highest rate of breast cancer per capita in the nation. Sometimes we're first. Right now, we're second. I'm the champion of Public Act 22-90, the Connecticut law that mandates the earliest possible early detection of both breast and ovarian cancer without an insured having to meet punishing deductibles and other out-of-pocket costs and all the other miserable burdens you insurance people had been saddling us with in order to get essential follow-up diagnostic testing after an inconclusive screening mammogram, usually due to dense breast tissue, which may hide a malignancy. I think you've asked for your own comeuppance, and your burden is health insurance mandates. And I see there's been quite a few complaints about mandates around this room lately. I think it's disgraceful that you're trying to slap insureds year after year with health insurance rate increases. Sometimes I don't know how you sleep at night. Stop complaining. No one is listening. You should thank me and all the other champions of the dozens of Connecticut mandates that encourage early detection and prevention of a myriad of diseases that you people, millions of dollars, that save you people millions of dollars for late stage care. You're welcome. Oh, and congratulations, you folks from United Healthcare. I think that was a fellow on the screen earlier named Mike. Was there anybody else here from United Healthcare? Congratulations, you folks from United Healthcare. Last Friday, I heard that Warren Buffett bought 5 million shares of UNH last Friday for a whopping $1.6 billion. What a nice cash infusion. Looks like you won the Powerball. So what are you doing here with a tin cup, trying to pry more money for health insurance from people you see here who can least afford your outrageous premium increases? Let me conclude. I'm well aware that today's public hearing concerns only health insurance rate increase requests, but I'm curious about something. Why don't you people at the Connecticut Insurance Department include in today's public hearing, or maybe in the near future, a public hearing regarding the outrageous and constant rise of premiums, this is related, on long-term health care insurance? It's about time that you folks, I'm asking you, please do something to help the 100,000 Connecticut long-term care health insurance policyholders. I'd like to hear from some of the CEOs and actuaries from the long-term health insurance companies the next time you hold one of these public hearings at the Legislative Office building.
Thank you. And for the record, we did hold a few years ago during my tenure.
What about the near future?
We
Not
did
a few
hold
years
it.
ago.
We did hold a public hearing, and we
Where?
had in this building with executives and actuaries from long-term care companies as we share the concern at the need for long-term care and the increasing prices. This is not something that we are not aware of. This is something we have sought to work with companies on. Our primary responsibility as regulators, we have to ensure solvency. We have to make sure that the companies are able to pay the bills when they come due. And that's the public hearing, I will tell you, I remember it was very well attended, not necessarily collegial. It was contentious, as I would expect it should be. And, you know, people need to know. And we keep working on it. We keep trying to make things better. Thank you.
To mention what one of the other gentlemen who are hit home runs today in their testimony about that, okay, I have Transamerica life insurance for my long-term care. I've had the policy for more than 20 years, okay? I have a 400% rate increase since day one and to now, okay? I'm in the process of thinking seriously about dropping the policy, as are many of the other people that I have talked to casually over the past year, okay, who have dropped their policy. Now they don't have long-term care. Well, hello, Medicaid, and thank you, taxpayers of Connecticut. This is such a serious problem for seniors.
Completely understand, and I will tell you, I have a long-term care policy myself. I understand it, but we have to, as regulators, look at all parts of the story. But this is not a long-term care hearing, so. why don't-
Transamerica Life,
why-
Transamerica
separately,
Life
separately.
has a net asset value of $407 billion. The CEO of Transamerica, the long-term care division, is a net worth of $20 million. And we keep getting such increases that we have to drop the plans. They want us to drop the
Thank you,
plans.
but this is not a long-term care hearing. I appreciate your passion.
Appreciate the
and
fact that you
feel-
let me talk a bit.
Yeah, feel free to reach out to our office. We can have a further discussion on this. And let me turn to Allison.
Up next, we have Karen Siegel.
Good afternoon, everyone. My name is Karen Siegel. I'm here today on behalf of Health Equity Solutions. We're a statewide nonprofit organization with a focus on advancing health equity through anti-racist policies and practices, and are grateful for the opportunity to share some comments on rate filings today. These initial rate filings request large increases that don't reflect the expiration of enhanced premium tax credits, HR1, or recent rulemaking, each of which is projected to result in larger increases either this year or in coming years. And as you know, health insurance in Connecticut's already unaffordable for many. The recent statistics from the Connecticut Healthcare Affordability Index suggest that 1 in 5 people enrolled in the individual market already cannot afford their insurance. And due to bias in our employment, education, and other systems, Black, Latino, Latina, and other people of color comprise a disproportionate share of Access Health enrollees. So this is a health equity issue to us for that reason. Recent federal changes guarantee that things will get worse, but Connecticut does have the opportunity to mitigate some of this harm. We are grateful for the CID's support for considering affordability in the rate review process and urge scrutiny of these filings with that lens. Rates that are based on excessively risk-averse actuarial assumptions or that reflect a failure to negotiate adequately with providers should be deemed unaffordable. There is, I'm returning to Connecticut after 2 years at CIO. I spent more time than I ever thought I would looking at URRT filings in that role. And there is significant latitude in actuarial assumptions, and we're really just asking for your acknowledgement of that and consideration of the degree to which the increases are really necessary. And we wanted to respectfully offer 4 recommendations. First, to require issuers to explain the actions they're taking to reduce costs and improve value, and to cite any large provider or provider group that's failing to negotiate rates in good faith based on the actual cost of care. Second, to scrutinize rate increases for excessive margin, seek clarification of justifications for rate increases and issuers' efforts to control and define underlying costs. Third, to consider seeking additional authorities to more directly regulate rate development. And fourth, in the near term, to work with enrollees in Access Health, the Office of the Healthcare Advocate, Office of Health Strategy, and others to ensure that communication about administrative barriers to enrollment in Access Health, things like new tax filing requirements and benefit changes, are clear and reduce procedural disenrollments and confusion. This is a really pivotal moment to leverage the rate review process to protect enrollees, reduce disparities, and ensure that everyone in Connecticut has access to care. We're grateful to the insurance department and also to your colleagues from the Attorney General's office, OHS, Access Health, and the Office of the Healthcare Advocate for your efforts to protect consumers and your willingness to hear these recommendations. And of course, would welcome the opportunity to discuss in more detail with you at another time. Thank you.
Thank you. And before we move to the next person on the list, there is one thing I neglected. I know there's going to be a hearing in this building in early September, and let me just ask Representative Meskers if he could share some more information on that.
Yes, it's from the chair of the Insurance Committee, Representative Wood. She wanted everyone to know that there'll be an informational forum on the federal cuts on September 10th at 10 a.m. in the LOB. And we'd love everyone who would be interested to come and participate. And that's basically for all of you who happen to be dialed in today. Thank you. Thank you, Commissioner.
So that's September 10th, 10 a.m. right here in the LOB. Allison?
Up next, we have Tanya Moorer.
I'm assuming this is already on. Lovely.
It is.
Great. Tanya Maurer, I'm from Ampston, Connecticut. I am an educated consumer. I'm a member of Access Health, and I am generally healthy. Thank you for the opportunity to speak today. Now let's get personal. We've heard a lot of data points today, so I want to get real personal, and I will be sharing information that I would assume very many people in this room would be very uncomfortable in sharing. So give me some grace. I am 58. I'm married. I'm currently employed. I might not be after this. My husband is not. We have 2 cars. We own a house. I have 2.5 dogs, no kids. I was laid off in September 2020 from United Health Group, specifically Optum Care. I had a 6-figure job. I get it. I understand the whole process. I did not have an opportunity to get another job because of COVID in my space of work. I declined and decided to stay home and care for my mother that has Alzheimer's. That was full time. After Cobra, I went to the exchange. I got an Anthem Silver plan. My husband had to go in for a hip replacement. We looked at Husky. Guess what? Not all orthopedics take Medicaid. Do you want an average provider to install new parts in your body? Or do you want the A game? We stayed with Anthem through the exchange. My mom has gone into memory care. I went back to work last year. Great. Small business in Connecticut. I was making $65,000 a year at the time, maybe. I was just laid off. I had gone to their health plan. I was just laid off in June of this year. I went back to the exchanges. Luckily, I was able to go back on the same Anthem Silver plan. I've been in a new job. Yay. Last 2 weeks, new job. I'm making $60,000 a year. That new business does not have health insurance. I must stay on the exchange. With that said, Alzheimer's runs into my family, right? I advocate for myself. I know the system. I advocated for a memory test. My last physical came back. I am now down 2 points on that memory test. I testified on behalf of the biomarker measure for insurance to cover on purpose. We need early detection. Now let's get to rates. When I lost Cobra, I went to the exchange. I was paying about $1,800 a month. That does not include dental, and it is a iffy vision plan, and it's high deductible. In 2024, I was paying $2,120 a month. How many of you all are paying that? In 2025, I now am paying $2,309 a month. How many of you are paying that? In 2026, no tax credits? Don't know. Rate increases? Don't know. Inflation, recession? Don't know. Possible infusions for Leqembi because I might be diagnosed with mild cognitive impairment. Who's going to pay for it? Reminder, I'm 58. So many unknowns. In closing, you all are a cog in a wheel. It's called homelessness. Is that extreme? You bet it is. Homelessness comes in many different flavors. The situation starts from somewhere. You are all on the front lines because the healthcare system is broken. It is very broken. I know. I work for Aetna. I work for United Health Group. I get it. I have a mother with Alzheimer's. I go to urgent care. It sucks. I'm on the front line too. Going forward, can I afford healthcare in totality? I don't know. Will I qualify? I can't qualify for Medicare. I'm too young. Will there be payers in my market? Because apparently I can't get a job for 6 figures that covers insurance. What is the quality of care when it comes to Medicaid? What are the options? I ask you all to sharpen your pencils, look at the overall problem differently, and basically take a look at what we can do going forward in totality. That's all I have to say about that. Sorry to go over.
Thank you for your courage. Allison?
Up next, we have Pamela McKeever. Moving on, Sheila Powers. Gretchen Schugertz. Deb Dauphiné.
Good afternoon. My husband and I have owned a small seasonal business for 23 years. This past June, typically one of our biggest months, we didn't even cover expenses. Those expenses do include health insurance for ourselves and for our employees. This type of loss has never happened, and it is a sign that many people are struggling more than ever. This uncertain economy will not harm the health insurance companies because their customers are captive. We don't purchase by choice. As they do every year, while much of their customer base struggles financially, the insatiably greedy insurance companies want more. As almost everybody in this room knows, including the decision makers, they do not use most of their increased rates to help their paying customers. The increases go mostly to their shareholders, yielding larger bonuses to their already obscenely wealthy executives. It is not quality or accessibility to care. They are a reverse Robin Hood story. Take from the poorer to give to the richer. While mine and other businesses in this state lose money, why do they have the right or the need to make higher profits year after year? Shame on them. Shame on anybody who allows it. Every year, they tell their woe is me stories as they spin their numbers like a shell game, creating a false need. They ask for more than they expect so that when they are given the lesser, it can appear like a winning compromise. When a scam artist reaches out, is it a win to give them some of what they asked for? This spin the numbers game is dangerous. Myself and other constituents are always the losers. The only winners are the already wealthy and the panel members who get to keep their jobs. We, the losers, always suffer financially, often suffer medically because we cannot afford our $6,000 deductible after paying thousands in premiums. And in some cases, they actually die. People's lives are not game pieces. I wish no will ill on the people on this panel, on the people in the industry. But I do wish shame, because the personal and professional legacies are ones of doing harm to others to make other people wealthy. Is that what they want their children and grandchildren to know? Do they want them to know the truth about what they really do? I wish them shame in the hopes that they use their skill sets and talents in a way that helps rather than harms. Right now, I have an active complaint with the state.
It's my third complaint over the past several years for being billed for my preventive breast screening. I won the last two. I will win this one. I am tired of the system that makes the customer do the work to correct the errors. I am tired of speaking every year and having the number spinners win. Please do not, as has always been done in the past, give them less than they asked for, because that is still a loss for all of us, feeding into the reverse Robin Hood game of taking money from the less wealthy and giving it to the rich. Many of us, like myself, will struggle more financially this year. This is a situation of a clear right and wrong. Please do not take from us again so that the rich can get richer. Give them nothing. Any other outcome is a loss for the citizens. Please make this year the year that you make this unethical, harmful pattern stop. Thank you. And one moment just to please respond to one of the questions earlier. No, I haven't utilized because I can't afford to. And no, I cannot afford the increase for myself and my employees. Thank you.
Thank you.
Up next, we have Lynn Dove.
Hello, my name's Lynn Dove, and I live in Andover, Connecticut. And I'm speaking mainly as a consumer of health insurance. I'm self-employed and I get an individual plan off of the marketplace. I get an Anthem Gold plan. Every year my rates keep on going up and up, and what I get in coverage declines. This last year I broke my wrist and I only have a $2,000 deductible. So I thought like, okay, I can handle that. But I ended up paying over $6,000 because there was things like my wrist had gotten casted in the emergency room and they had to take it off to take x-rays at the orthopedic, and Anthem said that putting another cast on was not medically necessary. I kind of wondered if I was supposed to hold it until I got surgery. And then they decided that the hardware that got put in there was a durable medical expense. And so that was only covered at 50%. That's kind of like crutches are durable medical expenses, not surgical supplies. And, but again, it gets put on the consumer to go back and fight and say, hey, a cast is medically necessary for a broken wrist. And so they're asking for increases in rates. But there's like, it's kind of like saying, okay, pay for the care, what you're going to get up front, but we're not necessarily covering everything. And what gets covered gets less and less. And so, we end up trying to plan for what the insurance rates are, and then to get extra more and more and more and more costs. And it's become unaffordable. Thank you.
Thank you.
Up next, we have Liz DuPont Deal.
Good afternoon, Commissioner Mace. I'm Liz DuPont Deal. I'm the Associate Director of the Connecticut Citizen Action Group. We report annually on the greed of the health insurance companies, especially those that killed the public option here in Connecticut in 2021. Health insurers overall made a record-breaking $71.3 billion in profits in 2024, according to a new national report. And while profits for some companies are slightly down, even they further enriched insiders with increased stock buybacks, dividends, and executive compensation, according to our new report, which is available at ccag.net. Government must play a larger role in exposing the vertical integration that is allowing these companies to enrich themselves at the expense of our health. CID needs to shine a light on this profiteering from self-dealing and collect and share data to educate the public about these abuses of power. I want to call out just a few items from our report. Stock buybacks is the practice of companies buying back shares of their own stock and has been criticized as a way to inflate share prices and reward insiders and already wealthy stakeholders. Companies could instead opt to invest in employee wages or benefits, research, facilities, or lower rates. In 2024, Elevance Anthem spent $2.98 billion, that's billion, on stock buybacks, whereas United Health spent $9 billion. CEO compensation had United Health at $26 million, which is a CEO to employee pay ratio of 348 to 1, whereas Elevance and Anthem had $20 million, a rate of 370 to 1. Finally, profits were for Elevance Anthem almost $6 billion, whereas United Health was $14.4 billion. I highly recommend a new report by the Center for Health and Democracy and Arnold Ventures on United Health, showing that it is the fourth largest on Fortune 500's list of American companies. It employs or has close contractual ties to 90,000 doctors, or nearly 10% of the U.S. physician workforce. United contains more than 2,700 distinctly legal entities, and 30% of the company's total revenue is now being generated by its own internal business entities. It denies 33% of claims it receives. Consider your health insurance company employs your doctor. Your doctor refers you to a specialist whose practice is also owned by your insurance company. That doctor writes a prescription for a drug, which is authorized by a pharmacy benefit manager that your insurance company owns. They profit at every step. While United Health is the most visible perpetrator of healthcare greed, other companies serving Connecticut are also harming our health. Cigna pulled out of the small group market after promising to offer plans as part of its effort to kill a public option in Connecticut. CVS, the owner of Aetna, continues to hollow out its operations and commitment to the state. The consolidation and vertical integration of health insurance companies is out of control. They are wiping out local pharmacies, increasing premiums and drug prices, and undermining our quality of care. We urge the CID to reject these proposed rate hike increases and to lift the hood and do a much better job of limiting the self-dealing. In previous years, we have not analyzed the existing rate hikes adequately. Ratepayers and employers need the CID to take them apart and see what's behind them. We must do this now, as H.R. 1 is set to raise healthcare costs for people by eliminating tax credits that have kept health insurance affordable and will result in even higher uncompensated care cost shifts. Thank you. Our full report again is available at ccag.net.
Thank you.
And last, we have Christian Damiana.
Good afternoon. My name is Christian Damiana, and I serve as the Public Policy Manager at Mental Health Connecticut. I coordinate a coalition of more than 25 organizations representing tens of thousands of psychiatrists, psychologists, nurses, and other mental health clinicians and advocates. Together, we work to ensure that behavioral health treatment is accessible and covered fairly. We're deeply concerned about the proposed 2026 premium increases. These rate hikes come at a time when families are already stretched thin and struggling to access care. Year after year, Connecticut consumers are asked to pay more. Yet, when it comes to behavioral health care, they're not getting more. They are still facing the same thin networks, the same long wait lists, and the same brick walls when they try to use the coverage they are paying so much for. Meanwhile, insurers continue to post record profits and even devote premium dollars, however small the percentage, to exorbitant compensation packages and to lobby against the very behavioral health access improvements their own policyholders need, such as parity reform. That is nothing short of an insult to the people footing the bill. Raising premiums without measurable improvements in service availability or network adequacy is unjustified. The department is tasked with ensuring that rates are not excessive, but what could be more excessive than charging consumers more while leaving them with the same limited access to the very care their insurance is supposed to guarantee? If insurers demand higher premiums, then consumers deserve to see clear, documented improvements in their ability to find timely in-network behavioral health care. This is not just a matter of fairness, it's a matter of public health. When coverage becomes too expensive, but not more usable, people delay care, conditions worsen, and costs ripple across our entire healthcare system. Families are left paying more for less, and trust in our healthcare system continues to erode. Looking ahead, we should also turn an eye to SB 10, which our coalition was proud to lead the legislative effort in support of. Beginning next year, the law will allow the commissioner to additionally consider affordability in the rate review process. Of course, we know regardless of whether an 18% increase is deemed actuarially excessive, it is plainly unaffordable for working families across the state. Coverage that is too expensive to use is not meaningful coverage at all. On behalf of our coalition, I urge the department to carefully weigh whether these proposed increases can be justified in light of stagnant access. Connecticut residents deserve insurance that delivers real value, not just higher bills, record profits, and empty promises. Thank you.
Thank you.
It looks like Gretchen Schugertz is back. Do you? Okay, never mind.
No? Could you verify, Allison, that we got to everybody from the list, including the people on Zoom?
That's correct.
Before we conclude, I just want to make sure here in this room, is there anyone who signed up to testify who did not get a chance to speak? Okay, then I just want to thank everybody for participating in this. Your insights, your inputs are greatly appreciated. This is always a difficult time. And it brings us back to the purpose of insurance, being here for people when they need it most. I do want to note, and they may have left, but I will thank our partners from the Office of the Attorney General, the Office of Health Strategy, the Office of the Healthcare Advocate, and Access Health Connecticut for participating today. I want to acknowledge and thank representatives from the Connecticut Hospital Association and the Pharmaceutical Care Management Association for attending and participating in today's information session. I want to thank the representatives from Anthem, United, and Connecticut for participating in this discussion, as well as the members of the Insurance and Real Estate Committee, elected officials, and members of the public. Thank you all for your time and your interest. You can expect to see the final rate decisions announced in early September. And just as a reminder from Representative Wood and Representative Meskers, there will be a hearing on the effects of the federal changes September the 10th at 10 a.m. in this building. I would encourage you to attend. Thank you all.